Imagine of the Jasmine Mill. Having someone to hold your hand while many stages of those. You know problems you have to. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you.
One, two. Check. Water. Two. Like that. One, two.
symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa, having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine.
Ladies and gentlemen, thank you so much for your patience. Our conference will begin in about 2 minutes. Thank you so much.
Il faut säga bla bla bla. No. Check, check.
Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa. Having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication to holistic treatments to help the body, mind, and soul. Imagine having all of that in the comfort of your own home, surrounded by the people you love. Imagine being supported in your journey, whether at home or at the Jasmine Villa, having someone to hold your hand through the many stages of illness. You no longer have to imagine. Thank goodness for Jasmine. Imagine having a team of professionals in your family, managing symptoms, providing reassurance, answering your questions, and supporting you and your family through life's toughest decisions. Imagine having the best care possible, from the right medication.
Good afternoon, everyone. Well, that was really quick. I want to say thank you guys for all coming and for your patience in regarding us starting later. I think this was definitely Cayman's time and we didn't want to get started and have people still coming. So we took our time in getting started. But at this point in time, I'm going to welcome our medical director, Dr. Virginia Hobday, up to give the opening remarks. It's a higher step. This one is be smaller. You got it?
So many of you here. We debated whether to open the room up or have a smaller room, and I'm very glad that we did open it up so we could have more space, and people will come in during the course of the afternoon. So this is our 7th conference. We do them every other year. So for 14 years, we've been doing this. This is the 2nd conference that we've had online availability for. So last time it was completely online because of COVID. And despite that, we had very good attendance, very good feedback. And so now hopefully with this amalgam of in-person and Zoom, people will be able to enjoy it if they're not actually able to make it in person, because we do have an incredible array of wonderful speakers. And so it's now my privilege to introduce them. The title this year is Caring for the Whole Person in Uncertain Times. And even though we're through the worst of COVID, I think that experience has changed certainly changed our practice a lot during COVID with hospice care, but we kept going, and I think we learned valuable lessons from it. So our first presenter is a friend of mine and a very accomplished lady and doctor. Her name is Dr. Sangeeta Awashti. She's a board certified psychiatrist. She trained in the US at UT Southwestern Medical Center and is now at BHAC in the Cayman Islands. She has served as an onco-psychiatrist working in oncology at the City of Hope Comprehensive Cancer Center. She's been treating patients with cancer or end of life, and that is her passion, and she strives to help her patients find their spark. Through the journey of life, Dr. Awashti has learned what it means to be herself a cancer survivor and thriver. She feels this personal experience has given her a deeper perspective on finding one's inner strength. She encourages her patients to employ a holistic approach to wellness with lifestyle modifications in habits, thought processes, nutrition, and exercise, along with medications and therapy if needed.
Thank you so much, Dr. Hobday. Thank you so much from the staff of Jasmine. Thank you for that, for the clicker. Let me get myself situated here. I really welcome this opportunity to speak to you all about a subject that's very close to my heart. Finding comfort, finding wholeness in uncertain times. As we look at life, almost all of us go through things that we don't plan out. Life is very uncertain. And we are always seeking peace of mind. How do we achieve that? And I think that we spend a lifetime trying to figure that out. Caring for the whole person in uncertain times. We wake up every morning with new hopes, new goals, new ambitions. We go to bed at night reflecting on what we have accomplished that day. We get through each day with these hopes and goals, and also with our support system. Well, people have studied what makes us whole. We have emotions within us that help drive how we react and respond to things. We try to strive to do exercise, have proper nutrition and sleep. And we try to find purpose in our life, find what is meaningful. Spirituality is something that's different for each person. It may be connecting to yourself, connecting to church, connecting to the nature around us, but it certainly helps ground us to this world. Social interactions are so important in our day-to-day life. Without those relationships and interactions, our life doesn't often feel complete. Within ourselves, we look for self-worth and self-esteem. With that self-worth, we're able to get through to our next goal. We spend a lot of our lifetime at work, and sometimes people are happy at work, sometimes they're not so happy. But trying to seek the good and the fulfillment in life makes us feel like we're doing something meaningful. Through these different components in our day-to-day function, we try to find balance. If we do too much of one thing, too little of another thing, then we don't feel whole. We don't feel happy. So we try to find balance in these things. Something that we can help our patients and fellow people in life strive towards is to determine manageable goals for themselves. And more importantly than determining manageable goal is learning how to follow through on those goals. We all make those to-do lists, but at the end of the day, we say, oh, we didn't do this, we didn't do this, we didn't do this. But instead of reflecting on what we didn't accomplish, maybe we switch that and reflect on what we did accomplish. Even if it's 1 out of 10 things, you at least have the next day to try the next things. when we are faced with a terminal illness, whether it's cancer, congestive heart failure, renal disease, pulmonary disease, or any neurological disease, our whole life is thrown off balance. Nice music. Our whole life is thrown off balance and we don't know what to do. This is where palliative care, psychiatric care, people around us, that's where people are there for helping us try to reestablish that balance. Dr. Elizabeth Kubler-Ross came up with this grief cycle. And this grief cycle is important not just for facing terminal illness or death, but for any change in our life, any drastic change. When we first are told of something different, then we first sometimes encounter that with shock or disbelief. And then anger, why did this happen to me? Bargaining, if only I could do this, then maybe I could do something else differently. People sometimes will encounter depressive symptoms and anxiety symptoms, feeling hopeless, feeling angry, feeling overwhelmed. Then our goal is to find acceptance. In this journey of change, loss, grief, our goal would always be towards acceptance. Now, this grief cycle is interesting because it's not linear. People can advance to bargaining or acceptance and go back again to disbelief. You can go through the journey of being told you have cancer, not believe it, then believe it. I remember that the day that I was scheduled to have a mastectomy, I told my husband with great confidence that I'm sure the pathologist is wrong. We don't need to go in for the mastectomy. So he said, no, we're just get showered and get going. We're going. But even I, as a physician, had difficulty accepting that this could be my fate because I didn't do anything wrong. We bargained, we're angry, but we work towards the acceptance. And I don't think that even as a psychiatrist working with cancer, that I couldn't come to terms with the word survivor even until maybe 5 years after I had cancer. To me, that was like something that was reminding me that I encountered something that I never asked for, to be a survivor. Often heard patients say they're looking for their new normal, or they're living with their new normal. People have spoken with a lot of patients and found that patients somehow get through this, not necessarily to find a new way of being and a new way of living. Oftentimes people come out on the other side of the cancer journey with a renewed outlook on life, seeing that some things may be more meaningful. Survivorship in essence begins the day that you are diagnosed. We are here for Jasmine, the Palliative Care Center, and the goal of palliative care is to maximize quality of health, quality of life. Patients who are facing a life-threatening illness as actively as possible. I worked at the City of Hope Cancer Center. This is a place where my father first came to work when I was 4 years old. They have a beautiful water fountain in front of the City of Hope with a mother, father, and a child. The parents holding the child up and the water spraying around, and it signifies life. It was a very special place to me. And then a few years later, my husband and I, who you'll hear from later, he's an oncologist, we moved back to City of Hope. And it was a very special feeling for me to go back there. In their rose garden, they have this golden gate. And the golden gate has inscribed on it the motto of City of Hope, which is, there is no profit in curing the body if in the process we destroy the soul. To me, I took that to heart because it's the union of mind, body, and soul. So often people, society tells us the mind is separate from the body. The soul is separate. We're treating your symptoms. We're treating your cancer. We're treating your medical illness. And we forget to treat the person as a whole. So this spoke very strongly to me. And to this day, I practice this way. Patients have been surveyed as to what they feel quality of life is. What things are most important to patients? Patients state that cognition is so important, being mentally alert. And if you look back at yourself or family members who may have reached an end of life, them being able to convey their feelings, their emotions, their thoughts to you is so important. Patients want to find happiness and gratitude for things that they have experienced in life. They want to live those days that they have left with joy rather than with despair. And I think that that's an important goal of palliative care, is to help them not feel that despair and hopelessness. Patients have said about healthcare that, of course, it's important to get excellent healthcare, but it is also very important to get kindness from us, to have that extra smile, that extra hand on their shoulder, to let them know that we're there with them through that journey. This is very meaningful and important to patients. People have always stated that retaining independence as long as they can is so important. Retaining the thought that they are not a burden to somebody else, that autonomy gives them a sense of empowerment. Physical strength, being mobile, being able to walk, being able to go to the bathroom, being able to feed yourself. These are very important and important to allow people to do for themselves as long as they are able to. Preparatory things, allowing people time to say goodbye. And this is where palliative care is also so important, because we help prepare the families and the patients that the end of life may be near. Maybe you take care of the things that are important to you. Maybe you take care of saying goodbye to someone, making preparations for your funeral the way that you want. There's an motion in America very strongly for making an advance directive when you're diagnosed with a terminal illness. A very nice advance directive that I like is called 5 Wishes. And in it, you have the liberty to speak to your family about things that are important to you, what music you might want at your funeral, how you want things done, what things are important to you. So often when our loved ones are passing away or our patients are passing away, we don't ask them, what is important to you? We're so busy trying to help them survive that we ourselves are scared to ask them, what is it that you want? What can I do for you besides just treating you medically? Then spirituality. When you're at the end of your life, the natural tendency is to reflect on your life and go through and think, what did I do in life that will live on beyond me? We all want to be remembered in some way. So what was our purpose in life? What was our meaning in life? One book that I read after I had cancer was The 5 People You Meet in Heaven. I don't know if any of you have read that book, but it's an amazing book that talks about a person going through life and dying tragically young from an accident. And he had spent a bitter life always wondering what his purpose was. When he passes away, he met 5 people, some who he didn't even remember who they were. But through that book, he gained an understanding of what his purpose was in life. So I always try to recommend books for my patients. When Breath Becomes Air is another very poignant book. I don't know if any of you have read that, but it's about a doctor who passed away from cancer. And to me, when breath becomes air, means that same breath after you pass away, it becomes part of just what's around you, just air. So why is quality of life important? Why do we focus so much on quality of life? As Norman Cousins said, death is not the greatest loss in life. The greatest loss is what dies inside us while we live. So often when we're given a terminal illness diagnosis, we are focused upon death. We forget to start living. We forget that each day that we're just thinking about dying, we are wasting that day of life. So what is psychiatry's role in palliative care? Psychiatry can help improve the psychiatric symptoms. And when we help improve the psychiatric symptoms, time and time again, it's been shown that that improves quality of life. So why are we so scared to go to a psychiatrist? We're not bad people. Why are we called a shrink? But I think that society places a stigma on mental health, mental illness. We think that the mind is separate from the body and somehow we should be able to control what our mind thinks. And that's not always the case. In fact, depression occurs in 25% of cancer patients. This is something that as providers and people who take care of patients, we need to be aware of and ask patients, have you been feeling sad for over 2 weeks at a stretch? Do you have any problems with your sleep? Are you waking up several times at night or too early? Do you not have interest in doing things that you used to enjoy? Is your motivation decreased? Are you feeling guilty for everything? Is your energy decreased? Is your concentration decreased? Is your appetite either increased or decreased? Is your activity level either increased or decreased? And most importantly, have you had any thoughts of suicide or self-harm or hurting anyone else? Anxiety, as we've heard so many people tell us that I'm so worried about this. I'm scared what will happen to me. I'm scared what will happen to my family. This excessive worry. Anxiety occurs in 45% of cancer patients, which is a huge number. Generally occurs in 20% of the general population, depression in 8% of the general population. This fear of loss of control. So if we can address these things with our patients and help them talk about these things, it certainly alleviates anxiety. Some of the things that we can do in our practices are screening tools for anxiety and depression. This is a very rapid screening tool called the PHQ-4, and it's just 2 questions for anxiety, 2 questions for depression. And if these are suggestive, then you can do further screening tools like the PHQ-9 for depression and the GAD-7 for anxiety. These are simple tests and very reliable. So the Dalai Lama said, the purpose of our lives is to be happy. So why is it so hard to find that happiness? We strive every day to find happiness, and we don't know what it means. We don't know. One day we're happy, the next day we're sad. Is that a mental illness? No, that's just life. So how do we find this happiness? What do we need to do? So there's a balance between feeling happy, feeling sad, but when it becomes pervasive, occurs for more than 2 weeks at a time, and it affects your day-to-day living, then that's the time that your provider or your friends, whoever or yourself needs to say, hey, maybe I need to do something to address these symptoms. Maybe it's more than what I can handle myself. In that case, psychotherapy is extremely beneficial to people going through anxiety and depression. Exercise has been shown time and time again to be beneficial. Mindful meditation is incredibly important. I had a patient at the City of Hope who was a producer for TV network, very important, productive man. He was in his late 30s and diagnosed with leukemia. He had to go through a bone marrow transplant. He had 2 small children and a wife. He became psychotic from the medications that he was treated with steroids especially. And he had underlying bipolar illness, which was never diagnosed. So he didn't know which way to turn. He was referred to me, and I treated him first with medications and stabilized him. And then I suggested he attend mindful meditation in Los Angeles. He attended that, and through that, his life changed. Through palliative care, psychiatry, mindful meditation, he became once again a very productive person. He's still living. He still is living with gratitude, as he says. He has become the face of City of Hope. He's made so many videos for them and on social media. He thanks the supportive care medicine department for giving him his life back, in addition to his oncologists, of course. Music therapy has been shown to be very helpful. Music is powerful. We have so many emotions connected to music, happy, sad. Music allows us, even in times of grief, to be able to express those emotions. Crying is not a bad thing. Laughing is a good thing, but both things are equally important. Art therapy is very good, as is massage and acupuncture. What I do is pharmacotherapy, and we treat anxiety and depression in the patients with various medications, some of them being SSRIs, which are selective serotonergic receptor inhibitors, such as sertraline or escitalopram. These are useful in depression and anxiety, as well as neuropathic pain. We can also use selective noradrenergic receptor inhibitors, such as venlafaxine and duloxetine, which again help for depression, anxiety, and neuropathic pain. Bupropion is used also for these things, but also has a more stimulating effect. So is sometimes used for fatigue, which is associated with terminal illnesses. Mirtazapine is one of my favorite to use in cancer patients because it addresses the anorexia and the nausea and insomnia that patients often have at end of life. Benzodiazepines such as lorazepam are used for anxiety, as well as anxiolytics such as hydroxyzine and buspirone. A lot of patients at end of life tend to have a lot of itching or pruritus, and that is treated as well with hydroxyzine. Gabapentin has been shown in some studies to help with anxiety and neuropathic pain. Sometimes patients only have a few weeks to live. Our medications often take longer than a few weeks to take effect. In that case, some patients are just lying in bed, just waiting for death. And in order to help them live those last few days instead of waiting to die, we have used Ritalin in low doses of 5 milligrams to help with stimulating and cognitive effects and fatigue. So that has been very beneficial. Sometimes patients have delirium, and that is treated with atypical antipsychotics. What we can do as providers, friends, ourselves, in helping people learn how to deal with emotions. One of the worst things that can happen is that we keep our emotions bottled up inside of us. Some cultures, especially Asian cultures, it's considered a weakness to express your emotions. So what we can do to help our patients is to help them learn that it's okay to express those emotions, Writing in a journal is a wonderful way for patients to express those emotions. It also gives them a chance to reflect on their own life, to remind themselves of the things that were important to them. Art is beneficial, and of course, physical activities, yoga and meditation. Music, sharing feelings with trusted friends and loved ones, giving people that space, asking them, how are you doing? And then not just walking away, but actually sitting down with them and saying, how are you doing? Was it hard waking up this morning? Are you hurting here? What have you done? Have you gone for a walk today? But just reminding people that they're important and giving them space to talk with you. Sometimes people state that they're not comfortable sharing those emotions because they feel judged. They feel that they're a burden on others. And they look at their family members, and in their family members' eyes, they see death because the family members are so scared that this patient is going to die that they themselves don't know how to deal with that death. And that's where, again, palliative care is very helpful because it allows the family a chance to talk through those things. And then we have always heard that everyone has a recommendation for a cure. Just like if you're pregnant, everyone takes that opportunity to touch your belly. If you have cancer, everybody will tell you every treatment they've ever heard that could work for cancer. So it's important to tell our patients, develop your support system. We all know friends, family who have gone through something, and we tell them, or so they've heard, hey, you reach out to me if you ever need anything. But as almost all of us have been trained before in CPR, we don't say, hey, can anyone call for help? We say, hey, you, Ishani, call for help, call 911. You delegate to a person. So people in your life say, I can help you. You say, wow, thank you so much. So I need dinner on Monday night. That would be a great help. So actually to tell them specific needs, because people love helping each other. And so often the patient feels like a burden and does not ask for that help. So helping patients recognize, ask for help. One of the hardest things for me when I had cancer was to let go of things. I like to be in charge of things. I like to be in control. I like to know what's happening next. This was the hardest thing for me when I had cancer, was to let everybody else take care of everything. At that time, I had 4 kids, with my youngest being only 4 years old. To let go to my husband and family members and say, you guys do whatever you need to do. I'm going to do my job of healing, and letting patients know that that's okay to do. You can let go and ask for help. People often don't know how to do that. There have been websites made for this kind of task building, exactly, trying to organize meals, driving, transportation to places, to doctor's appointments. So I think this is an important thing to let patients know about. Hope is something so important. And I think that that's why that hospital is called the City of Hope. Because we get through each day with hope. When we lose that hope, we lose that will to live. So encouraging our patients on ways that they can maintain hope in their lives. It needs to be realistic hope, but hope indeed. Napoleon said, courage isn't having the strength to go on. It is going on when you don't have the strength. I learned this especially from my father in the last 5 months of his life. He, of course, taught me things throughout my life, but in his last 5 months, he helped prepare us for his death. He was a very strong man. In his last 12 hours of his life, he spent recalling meaningful memories. We laughed together, we cried, we shared. And when he wasn't able to talk anymore, he placed and entrusted my mother's hand into our care. Patients will tell us what they need. It's our job to listen with our heart. Thank you so much.
So before our next speaker, I just wanted to introduce you to our new medical director at Jasmine. She joined us a month or two ago. She's been coming over from Jamaica part-time, and she's been an incredible addition to our team. Dr. Natalie Sharp is an oncologist by training, and she has also done training in palliative care. She's going to talk to us later and present, so I won't do her whole bio until then, but I just wanted her to come up, introduce you to her, and she's got a few words to say to us now. So welcome, Dr. Natalie Sharp.
Hi, everyone. Good afternoon. So thank you for coming. Thank you for your interest in palliative care that has brought you here. I am so happy to see so many people here, and I am very excited and happy to be part of the Jasmine team now, and just trying to help grow the service and try to help provide support to the families, the patients, the physicians, anybody who's dealing with life-threatening illness in whatever way. So I hope you enjoy the afternoon, and I hope you get to learn something. Thank you.
Before we go on to the next presenter, I did not give anybody an opportunity to ask questions of Dr. Sangeeta. So if anybody has any questions, because it's sort of more relevant to do them just after you've heard the presentation rather than at the very end. So I'm sure she'll be happy to answer any questions if anybody's got any. Dr. Janga.
At end of life, it is very effective and used at end of life. It is. It is available, yes. Anyone else? Yes, I think it's something that we don't think about often, and we don't use it often enough. You know, at the end of life, sometimes we just let people go, but there may be something that they are waiting for their family to come. There may be a reason that they need to be more alert. Their family needs them to be there, and it is helpful.
Okay, thank you very much, Dr. Sangeeta, for that amazing, personal, and very illuminating talk, touching so many really, core subjects that we deal with. So thank you for that. Our next presenter is Dr. Shapir Rosenberg. He's going to talk to us about palliative surgery. We were just lucky enough to hear from him before this started, and he talked to us about palliative care in psychiatry, end of life in people who have chronic mental illnesses, which was a very new way of looking at mental illness. And sometimes when people want to die, that they have a chronic psychiatric illness, we need to let them do that and support them as we would with any other illness. So Dr. Rosenberg is a palliative care physician and a psychiatrist. He graduated from the University of Pennsylvania with a BA in philosophy. He completed his residency at the University of Maryland Medical Center, where he was inducted into the Gold Humanism Honor Society. He then completed a fellowship in hospice and palliative medicine at the University of South Florida and is now a palliative care physician and psychiatrist at Forbes Hospital. He has a passion for end-of-life care, teaching, and the medical humanities. He came recommended to us by Dr. Donna Thompson, who's an oncologist that we've known for many years, and she's always presented at our talks, and she recommended Dr. Rosenberg, and now that we've heard him talk at lunchtime, we know why. So we look very, very much forward to hearing about palliative surgery. Dr. Rosenberg.
Here was the irony of it. I originally started in family medicine, a family medicine residency in Chicago, before then transferring to doing a psychiatry residency in Baltimore. At the family medicine residency, we had suture clinic one day. A few weeks subsequent to the suture clinic, one of the family medicine faculty asked that I would come into his office to give me some feedback about my performance in suture clinic. He said in his 3 decades-ish of family medicine training, he had never seen a worse performance in suture clinic. So I found it ironic now and then that here I was standing before a room full of surgeons, in this case in New York City, giving a surgical grand rounds conference. But nevertheless, I want to thank Dr. Donna Thompson, who's sitting in the back corner, for believing in me since my days as a medical student, mentoring me, and continuing to be a source of support in my journey through medicine and life, and for nominating me as a conference speaker today. I'd like to thank Felicia for inviting me to be here and warmly welcoming me to the Cayman Islands. Are there any physicians in the audience? If you'll raise your hands, just by show of hands, so I have some sense of, okay. Other clinicians, raise your hand. If you're a clinician, a psychologist, social worker, or provider of some sort, okay. And are there any surgeons in the audience? One surgeon, okay, okay. All right. Well, this is my agenda. And I'll throw in some other things along the way. First, we'll start with a poem, and this comes from a Journal of Narrative Medicine at Columbia University, and I include poetry because I often think we have to use art in order to practice art. So this is called All Tuned Up. Mortality and morbidity rounds. Nobody likes them. The residency director speaks of, quote, quality, excuse me, it's actually hard, of quality assurance. The residency director speaks of quality assurance, as he must, but everyone knows the meeting is about mistakes that hurt or kill patients. The resident physician takes the chair in front. Mr. Chen was doing great. We got him through pneumonia. His numbers were all good. Finally, he was all tuned up. Then he goes and dies on me. The resident is a big man with a dramatic mustache. As a third year, almost finished, he's seen a lot. He shakes his head and raises his strong tanned hand to wipe tears from his cheeks. Dies on me. The director gently recalls the patient's advanced age. Maybe he was just tired, he says. Sometimes death's okay. So much of medical practice, particularly in the palliative realm, involves nuanced situations that demand attentiveness and close observation. So let's do a little exercise to practice this. And I'm going to invite you to tell me what you see. This is from a Peanuts comic strip, and I'll read the strip. So it says, so Lucy's in her booth. It says, psychiatry help, 5 cents. Charlie says, yesterday morning, I woke up very early. I just couldn't sleep. My bedroom faces east, and so I could see the sun coming up, only it wasn't the sun, it was a huge baseball. I think I must be cracking up. I think I'm finally losing my mind. And on top of it all, I feel terribly alone. Okay, the doctor says, now tell me more about this huge baseball. What do you think about that comic strip? Thoughts? What's funny about it? Why do we all laugh in the last box? We overlooked his emotions. Okay, there's a thought that it's classical Lucy. Okay, so she what? She only thinks about what she's thinking. Okay, so she overlooks his emotions. There's a thought. Anything else? Okay, now in the interest of time, I'll move things along. Now, how about the opposite? Is there an argument, and if so, what, in the comic strip, that she actually gets something right? What evidence is there that she gets something right? What does she do well? Good. So she includes the line, tell me more. She expresses that she's listening, and there's an invitation to share more. What else? What else? And what in the drawing suggests that something worked? What in the drawing suggests that something worked? Yes. They're no longer divided from behind the doctor's booth, behind the doctor's far-reaching desk, and the patient. They're on the same side. They're aligned in some important way. Okay. Now, interestingly, for those of you interested in psychology and psychiatry, although we might think she hones in on the baseball and that's the least relevant dimension of the patient's complaints, i.e. his loneliness, a possible psychotic break, etc., perhaps by actually inquiring about the baseball, she is pursuing a non-threatening way of, she's attempting to form an alliance in a non-threatening way. It's interestingly, the only bolded term is the baseball, meaning although we might think, gosh, he's isolated, he's depressed, he's having a psychotic depression, he's most concerned about the baseball. And she addresses that. She attends to that, the patient's chief concern, and perhaps not her own. So, okay, simply a little exercise, how we look at things and how we look at art to help sort of inform some of the nuance of how we attend to patients. Okay. 2 graphic art pieces. Graphic art has sort of gained an acceptance in multiple domains of medicine these days. This one could apply in so many realms. This one's called, this comes out of the Annals of Internal Medicine. It's called Please Don't Use Patient Names. And the old starch balding doctor says, please don't use patient names. It makes it very hard for me to remain callous. And then the second one, I think we all might be able to appreciate. It's called I'd Want a Natural Death. So the doctor on the right is listening to the older gentleman on the left, and he says, yes, indeed, I'd want a natural death. Just a few light shocks, some gentle chest compressions, a tracheal tube to breathe, several rounds of epi, and if it's not working, well, then just let me go peacefully. Okay. So I think I would call that ambivalence. I would call that ambivalence, and I'm sure that those of us in palliative care have seen that a lot. Okay. The prior speaker invoked Kubler-Ross, and I'm not going to show a video, but there is a video in which Kubler-Ross says that she hopes, I note the irony of this because I, of course, am a palliative doc and completed a palliative fellowship. Kubler-Ross herself says that she hopes palliative care never becomes a subspecialty of medicine. And the reason she says that is that it's her belief, and arguably one that should be shared, that doctors and providers ought to attend to their patients through to the end, that there ought not be an outsourcing, if you will, of palliative care to relative strangers, to people coming on the scene late in the game. Now, sadly, Kubler-Ross's desire, so much of what she did was taken up by the medical profession, and that wish of hers by one of its founders was lost, and so often it is in fact outsourced. Okay, more to our talk today. What percent of surgeries do you think are palliative? What percent? Give me numbers. And the next slide, you'll get a bit of an answer. What percent of surgeries are palliative? 1%? 25? 60%. We have one. 5%. Okay. 5%, 60%. Okay, so a wide range. According to one, well, the numbers that I researched, the articles I came across in preparing this talk, suggest anywhere from 5, as our surgeon suggests, to 25% of all surgeries are palliative in nature. Potentially a quarter of all surgeries are palliative in nature. Okay, now what do we mean by palliative? We'll come to in a minute. Of note, this is just one chart from an article finding that essentially the bottom right corner, 12.5% of all surgeries performed at this one hospital were palliative, and it gives a breakdown. For instance, almost half of all neurosurgical surgeries were palliative. 13% of urologic surgeries, 20% of thoracic surgeries, etc. So regardless, a very large proportion of surgeries are palliative in nature. We'll come back to what I mean by palliative in nature. By the way, as I'm just noting my notes, that study came from 20 years ago at City of Hope Hospital in Los Angeles, the cancer hospital. Okay. And there are a few cases that I'll intersperse in my talk today, which were used in a study comparing surgeons versus internists treatment approaches. And now, fear not, they're often, unlike used multiple choice questions, there are often multiple correct answers to these questions. So this question states, and it's kind of hard to read, patient A is an otherwise healthy 55-year-old man with a history of poorly differentiated adenocarcinoma of the appendix, so appendiceal carcinoma. He's maintained a normal lifestyle, though recently was found to have widespread carcinomatosis. He presented to the ER with crampy abdominal pain and distension, no flatus or bowel movement for 3 days. An abdominal X-ray series is done showing, and it was consistent with a complete bowel obstruction. So complete bowel obstruction in this gentleman with appendiceal cancer. His WBC count is 15,000. While participating in a patient and family discussion with the palliative care team, you recommend which of the following? So part of my talk today and part of my, when I gave a similar talk to the surgeons, was to think about what are the wide range of possibilities that can be employed when someone at various stages of diseases presents with a complication. When should surgery be employed? What type of surgery? And when could non-surgical alternatives be attempted? So the options here, again, there's no right answer, and we won't necessarily, in the interest of time, survey the room. But non-surgical management, for example, nasogastric, tube and bowel rest, or non-surgical management with surgical intervention if the patient doesn't improve, or non-surgical treatment altogether. You simply go for the cancer, chemo or radiation, or major surgical intervention. For example, a laparotomy with bowel resection and a colostomy, or minor surgical intervention, for instance, laparoscopic or an open G tube, a minor procedure like a PEG tube, or simply refer them to hospice. Now, obviously, some answers are more correct than others here, but there's a wide range of possibilities. Okay. So to talk about palliative surgery, we have to talk, of course, about what is palliative care and what is palliative surgery. I'm not going to spend a lot of time on the definition of palliative care. This comes from the World Health Organization definition, which I presume many of you are familiar with. but to the question of what is palliative surgery. So before I sort of offer on the next slide a little small definition, a working definition that I think will serve our purposes, we could pose the question as to whether we should define palliative surgery based on the preoperative intent, meaning what is our goal going in? What is our goal going in? Should we define it based on the post-operative outcome? What happened? What happened and where can we go from there? Or should we simply define it based on the patient prognosis? How will the patient do? What's our best guess to how the patient will do? And that will define whether this surgery we're about to do is palliative or non-palliative, i.e. with curative intent. Okay. And then some sort of academic / intellectual theoretical considerations. What if you go in to do a procedure and the tumor remains, but the patient's prognosis is good? Was it a palliative surgery? Again, I don't know that it so much matters for our purposes. What if no tumor remains, but nevertheless the person has a poor prognosis? What if no tumor remains, the cancer is taken out, but the prognosis is horribly poor? Would you nevertheless say it was a palliative surgery? Okay, and then even more theoretical, is an appendectomy in a person with incurable brain cancer a palliative surgery or not? Okay, so these sort of theoretical considerations, I was a philosophy major, these sort of philosophical considerations to define what is palliative surgery. This can be our working definition. Palliative surgery is, quote, the deliberate use of a procedure in a patient with incurable disease with the intention of relieving symptoms, minimizing patient distress, and improving quality of life. Okay. Relieving symptoms, minimizing patient distress, and improving quality of life. Okay. Now this slide and the next slide is the American College of Surgeons statement on palliative care. And it's from 2005. And I'm only going to read sort of my bolded part because I think that gets to the crux of it. The beginning part is a little summary of a definition of palliative care for the surgeons. So in the second paragraph here, although palliative care includes hospice care and care near the time of death, it also embraces the management of pain and suffering in medical and surgical conditions throughout life, as we all know. If palliation is taken to apply solely to care near the time of death or, quote, comfort measures only, it fails to include the life-affirming quality of active, symptomatic efforts to relieve the pain and suffering of individuals with chronic illness and injury. In this respect, palliative care is required, this is my bolding, palliative care is required in the management of a broad range of surgical patients and is not restricted to those at the end of life. So my intent in showing the room full of surgeons this in New York in the spring was to have their jaws drop and think, wow, we maybe ought to consider palliative care involvement much earlier on in our patients' courses. The tradition and heritage of surgery emphasize that the control of suffering is of equal importance to the cure of disease. That the control of suffering is of equal importance to the cure of disease. Okay. And then they include a number of statements on principles of palliative care, and we'll just focus on the ones I bolded. Number 4, to identify the primary goals of care from the patient's perspective and address how the surgeon's care can achieve the patient's objectives. Okay, which of course relates to those of you who are at my noontime talk, attending to the patient's goals, perhaps, and not the provider's goals here. And how it is, in this case, that the surgeon's care can achieve the patient's objectives. Okay. And later on, we'll come to questions of what if the patient's goals, if the surgeon can't provide that, or it's infeasible, or it's even unprofessional to offer such a surgery. Okay, and number 8 recognizes the physician's responsibility to discourage treatments that are unlikely to achieve the patient's goals and encourage patients and families to consider hospice care. Okay, so that's in the American College of Surgeons statement of principles. All right, another poem. This one is almost as if it was written for a presentation about palliative surgery. It's called Cut It Out. Cut it out. You know how much I hate it, how desperate I am to make it stop. Be gone. We both know you can do it. Obviously talking to the surgeon. We both know you can do it. You have what it takes to cut it out. The ability, the knowledge, the opportunity. You have my support, my insistence, my pathetic pleading. And yet you hesitate, prevaricate, insinuate. You are the deliberate one, want certainty, want more time. We're badly paired in this regard. I'm the anxious one, want answers, and frantic about time. I want you to be Nike, for God's sake. Just do it. Get me through it. Don't give me those excuses, the painful cliches that others use. Too big, too complicated, the timing is wrong, bad location, too inaccessible, too risky, not in my best interest. I'm not strong enough. Or my personal favorite and yours, not enough data. You know I adore you. Well, maybe you don't. We don't know each other that well. It's been a whirlwind relationship. You're handsome, gentle, kind, and you're the only one I have. I will remember you all my life, while I'm just one of the many who need you. We both know that I depend on you utterly and that I have no say in this relationship. I know that you care about me and my well-being, but you might decide not to cut it out and abandon me tomorrow, as I know you have others before me. You hold all the cards. Will you take pity on me? If I confess that I find this intolerable, try to see me as special, see me as strong, take a chance on me, even if I don't measure up to your criteria. I know that character isn't part of your criteria, but we're not talking elective surgery here. Okay, maybe you are, you're the voter. I, however, am talking life and death. You peer at scans and scopes and see cancer every day. You decide if it stays in or comes out, but this is about my life, my cancer, and we both know that only you can cut it out. I forgot if I mentioned these poems come from a journal of narrative medicine out of Columbia. I think I did mention that. Okay. All right, so this is an important slide, one of a few core slides to the whole talk. So what are some important considerations in entertaining the idea of performing a palliative surgery, a palliative operation? One is the odds of success in easing the symptoms. The odds of success in easing the symptoms, and those symptoms could be pain. The symptoms can be nausea, vomiting, jaundice, seizures, dyspnea, or hygiene. Hygiene when there are head and neck cancers, and the palliative procedure is not to cure the cancer, but for hygienic purposes. Okay. Another consideration is the durability of the success. How long will it last versus the recurrence of that symptom that you're trying to address, or the emergence of a new symptom, either because it came about in the course of sort of anticipated symptom development in the course of the illness, or it came about as a sequela of the surgery. What is the cost of the success? What is the cost of the success? I.e., what are the complications that could ensue? So often we're talking about very, very sick people. We're not talking about healthy people who come in needing an with an appendicitis and need an urgent appendectomy. These are often already very sick people. What is the cost of success? The price of ameliorating one symptom, but perhaps causing others, not to mention the long hospital recovery, etc. The quality of life before and the quality of life after. How are they doing now? How might it be after? These are all the very hard, nuanced conversations. There's no playbook for each of these situations. The duration of life before and after. How long would they be expected to live if surgeon does not operate? How long would they be expected to live if surgeon operates? And taking into account the post-op course. And then I say, but don't let attempts to extend survival outweigh the amelioration of symptoms, unless that's the patient's goal. Okay, meaning don't let attempts to extend survival outweigh. So if the patient says, all I care about are minutes on the clock in life, okay, you sort of have a green light, if you're a surgeon or if you're a palliative care doctor involved in this, to say, okay, if you understand what might transpire and we think that the surgery can afford more seconds, minutes, hours, days, etc. Okay, but if not, then let not that be your agenda if it's not the patient's agenda. Okay, more considerations. The patient selection, which encompasses things like the performance status of the patient. Oncologists are familiar with performance status. They often use sort of formal rubrics. I don't know if surgeons do or don't. Nutritional status, and their motivation. Patient selection, throughout all the literature I read in preparing for the talk, is the most important factor in successful surgical palliation. It's not surgeon selection, it's patient selection. Okay, by the way, why am I talking about all this to a room full of people, only one of whom is a surgeon? The answer is if you are involved with palliative care, you are very much summoned and called to be involved in these discussions, to weigh in about all of these elements. And interestingly, it's something that we don't often get much training in or much thought to. Okay. Other considerations, what non-surgical options exist? Can instead of an abdominal surgery, can other things be done, for instance, to alleviate social terrain of satisfying patients, satisfying surgeons? So what if surgeon feels confident that he or she can do the surgery and there will not be a tremendous complication burden or a tremendously difficult post-op course? But what if it's simply not worth it? What if it's simply not worth it because what if it keeps a person in a hospital or rehab for a time? What if the risk, simply even a small risk of death in the operating room, it could simply call into question the benefit of the surgery? On the other hand, what if a patient wants a surgery? What if the patient desires it and the surgeon doesn't think it will be beneficial? Is there something to satisfying the patient's need? And how else or how better can that be achieved? And we'll come to that. We'll hint at this in our bottom line here. The next line is timing. These considerations, these discussions often happen rather quickly. And the reason is that, as I say, the open window for palliative surgical interventions is narrow and closes very fast. Again, these people are often very sick, seizing a moment when they're as good as they will be for a surgery. Uh-oh, okay, just a few minutes left. I'm gonna have to move at a good clip here. Interestingly, patients are highly satisfied with their surgeon after palliative operations, even ineffective ones or ones that cause complications. And the thought there is, the surgeon might know going in that this will be a difficult post-op course. The patient might know that, but it was a way of showing the patient that the surgeon did not abandon them, that the surgeon did not flat out reject them. Okay. And then a quote from one of the articles, it was by a surgeon: "There will be times when the most appropriate decision a surgeon can make in the treatment of a terminal patient is not to perform an operation." And then simply to be clear, from the provider's standpoint, it's not abandonment or failure, it's actually honoring and dignifying a person. Okay, another case, maybe I'll skip that case in the interest of time. We'll come to the topic of consent and refusal. So how much time do we, and again, this is often where palliative team can be essential in helping the surgeon to obtain consent for surgery. How much time is spent? So this is a quote. In his memoir, Do No Harm, Stories of Life, Death, and Brain Surgery, British neurosurgeon Henry Marsh states, quote, "Informed consent sounds so easy in principle. The surgeon explains the risks and benefits, and the calm and rational patient decides what he or she wants, just like choosing from the vast array of toothbrushes on offer." He continues, "The reality is very different. Patients are both terrified and ignorant and will try to overcome their fear by investing the surgeon with superhuman abilities." So in one study, it took an hour to an hour and a half, one or over the span of 2 meetings, so maybe even 3 hours of really intense discussion prior to arriving at a consensus regarding a palliative surgery. These are not fast decisions, and lots of time should be invested in them. Basics of informed consent, which those in the mental health field here might be familiar with. A person has to, of course, have capacity to make a decision, and capacity itself consists of a number of elements, including understanding the situation, reasoning among various options that are presented to them, an ability to appreciate the applicability of those options to them and their situation, and the ability of the patient to consistently, the emphasis is on consistently express a choice, not be wishy-washy, one day yes, one day no, one day yes, one day no. They must be adequately informed, and they must not be coerced. They must not be coerced. Okay. There's this concept called surgical buy-in. And I pose the question this way: does consent for palliative procedure imply consent to remediate complications with that procedure? Often surgeons will want buy-in, meaning the patient understands what they're about to get themselves into, and the family understands what they're about to get themselves into. And they want not only permission, if you will, to do the procedure, but to attend to the person with all the potential ensuing complications post-operatively. if immediately after the surgery, the person develops a complication, ends up in the ICU on a ventilator, potentially needing dialysis, and then patient likely couldn't, but family then says, you know what, enough, we don't want this. It can lead to a tremendous sort of fracture and rupture in the relationship between the physician and the patient and the family. And so the hope going into these things is that there's buy-in for all that might ensue after surgery. Okay. It's difficult to measure metrics of palliative surgeries. And that's because so often clinical and surgical outcomes focus on survival or disease-free survival. So there's 30-day readmission rates, 30-day mortality rates, 5-year survival rates. But we're talking about a realm that's totally different. It isn't measured quantitatively, it's measured qualitatively. So patient-reported outcomes focus on other things like quality of life and symptom burden, the physical functioning of a person after palliative surgery, the social functioning of them after a palliative surgery, the psychological function, symptom amelioration, whether they had a prolonged hospital stay or a short stay, their dependence on any variety of these life support items afterwards, their burden to others, and whether they in fact didn't die at home if they wanted to die at home, or the reverse. The former is easy to capture and quantitative, and then this latter, the quality of life measures, are obviously much more difficult, as there's no validated quality of life measure for palliative surgical outcomes. There's this divide between doctor-defined adverse events versus patient-defined adverse events, where, for instance, mortality might be tolerable. Okay, doc, give me the surgery, and if I die, I die. I knew I was already seriously ill, so be it. But morbidity is not. Gosh, doc, yeah, I survived, but you left me so debilitated, so deconditioned, etc. We'll skip the M&M comment. And then I simply said, perhaps informed consent discussion should be framed less in terms of risk benefits and more about trade-offs and goals. Skip that case. The cases are good, but we'll skip them. Okay. Here are some symptoms, a list of symptoms that can be treated by palliative surgeons, but by palliative surgery. Pain, seizures, hygiene. We spoke about some of this, or we alluded to this a moment ago. Obstructions, jaundice, dyspnea, bleeding, instability. And of course, then there's the question of whether these should be best managed medically or surgically. Here are symptoms that often cannot be managed by surgical approaches: anxiety, depression, constipation, fatigue. Okay. I think this is a powerful poem that's worth reading. Okay, we'll skip it. If you want it, I'll send it to you. As regards communication about this, they talk in the literature about a palliative triangle, and that is patient, family, and provider. And it's the interpersonal interplay of all of those. I'm going to, in the interest of time, avoid reading to you from something. That someone describes it as having a spiritual and almost mystical quality to this dynamic. Surgeon factors that play into communication around this relate to time constraints, inadequate communication skills on the part of the surgeons. Often surgeons or physicians generally can be defensive, be unable to contend with emotion, can be neutralizing of patient concerns. Lucy, by the way, was not neutralizing. She dove right into Snoopy's or to Charlie's chief patient concern. Offering false reassurance, focusing on the medical details, and assuming a problem-solving stance. They can also harbor false belief that patients don't want to talk about dying. They can struggle with prognostication uncertainty, which is another place where palliative involvement would be vital, and they can fear eradicating hope. Patient and family factors that play into these discussions include race, religion, family dynamics, lack of family support, and simply an overall low health literacy where they really don't understand what's being talked about. It's been recommended, maybe the small little print at the bottom is the most important on this slide, that surgeons speak and that providers and palliative doctors speak in terms of best case, most likely case, and worst case. Best case, worst case, and then what's a most likely case in the middle. Okay, this is a nice painting. It's called Hug, and it was done by Robert Pope, who was a Canadian artist who died young of cancer. In the spirit of observation, who's the patient in this photo, in this painting? Who's the patient? Who's the patient? Okay, no, we're not an art a painting class or an art history class, you can't quite tell. And it's unclear where the IV line goes. And I think this painting nicely illustrates that in the setting of serious illness, the patient is the entire family. That's no secret to all of you who work in palliative care. Okay. 3 good questions to ask in considering a palliative surgery. And I know I just have a few minutes left. So here's some sort of good takeaway lines if you just need lines to borrow. If at the end of this year you die of this disease, how would you have wanted to spend this time? If we perform an operation that fails to cure you or fails to make you feel more comfortable, you might look back and be glad we tried it, or you might look back and regret being in the hospital away from your home. What do you think about those possibilities? Number 3, if we do not operate and focus on managing the symptoms that are most distressing to you, you might look back and be glad, or you might look back at the end of the year and regret not having tried one last treatment. What do you think about that? Okay, a nice quote between the difference between wishes and hopes. As Bal Formant, the father of palliative care, who you might be familiar with, states, hope is not the same as wishing. Hope is a perspective on reality, a point of view. It reflects a degree of inner peace. Hope is a child of the human spirit. It arises from an experience of personal meaning. Wishing, however, arises from a sense of need, dissatisfaction, and unrest. It reflects a sense of incompleteness. Hope is the product of adversity transcended, wishing of adversity denied. The focus ought to be on hope and not wishes. Okay. I'll read this poem because it's really beautiful and captures a little bit. We'll see if Felicia is willing to let me go a couple minutes over. What do the dying want? What do the dying want? Do they want words, tulip, beach, son, daughter, love? Or are words grapple hooks, dragging them back, unwilling, to the morass of the living? What do the dying want? Music to fill the cups of their ears, gentle vibration of violin, of harp, soaring arias or plaintive hymns? Or does music distract them from their deep burrowing? What do the dying want? The nape of the neck caressed, a hand laid lightly on the brow, a cheek pressed to gaunt cheek, or to be left alone, to slip modestly from their bodies when no one is looking, to leave without causing a fuss? What do the dying want? They don't tell us. They lie still on their beds, eyes shuttered, the bony architecture of nose rising above the cavern of mouth, air sucked in like wind, the chest rising and falling, that heart laboring on, a good faithful horse, until it too gives out. No one knows what the dying want. Wanting is what the living do. I think that nicely captures so much of our projections onto dying patients and not knowing what they actually desire. Okay, some ethical issues. There are a host of ethical issues in palliative surgery. For instance, will a surgeon not do a procedure that could ease suffering because of their own issues? And what about the notion of a prophylactic surgery, anticipating a potential complication of someone's stage 3, stage 4 cancer and prophylactically going to the operating room? There are a number of these ethical issues. We won't have time to delve into them. We'll skip that. We'll likely skip this, but the point is palliative surgery is given very little exposure at most stages of training. Okay, and this most of you already know. When should one request a palliative consult? And the answer is early on. The earlier the better to have these discussions. Why to do it? It can be vague. It need not be a specific reason. It can simply be to help with goals of care. And again, I'm talking to a room full of surgeons. It's okay that it be vague and they simply get palliative involved. And how? It's often important actually to ask the patient and the family, would it be okay if we ask our palliative colleagues to come on board? Otherwise, they can be shocked when they appear in the room. Oops. Okay. And then it's a subtopic within the realm of palliative surgery, and that is what should be done as regards a DNR in the OR. What should be done as regards a DNR in the OR? So someone already has established a do not resuscitate order, and then they go in for a palliative procedure. Should that automatically be revoked? should it be suspended and then re-implemented? Or should you have an entirely new conversation about undoing it? Well, here I sort of mentioned the four options. A bottom line answer for our purposes in the interest of time is something called a required reconsideration. The palliative team and the surgeon should likely have another conversation about going into the operating room, what could happen in the operating room and what could happen immediately afterwards, and whether to suspend the DNR or not. Okay. Skip that. Skip that. If interested, a few resources. There are actually two textbooks on palliative surgery. The American Medical Association Journal of Ethics had an entire theme issue last October devoted to it. A couple of nice books relating to palliative care. For those of you who teach or involved with teaching, medical students or residents of any specialty, there's a residence guide for surgical palliative care that's free online. The American Academy of Hospice and Palliative Medicine has a special interest group, a surgical and perioperative members. And then for those who were actually perhaps more interested in the poetry and the painting in my whole discussion, there are a number of nice conferences of medical humanities conferences throughout the country and some overseas too, and then some gatherings in New York and in Baltimore for those interested in that. Okay, and then a number of articles relating to palliative care and the arts, and then a few more articles that I used for my talk today. And I believe that's it. This was me and some surgeons. Okay, and some trainees. Okay, we won't have time for that. Thank you all for your time.
Thanks, Dr. Rosenberg. It's great. Having done a philosophy degree myself, I love to hear about art, or the art of medicine, the science of medicine, and how they're really intricately together, and they shouldn't be separated, which they often are. So, has anyone got any questions for Dr. Rosenberg? One over here.
Good evening, Dr. Brunsberg. I'm Dr. Smith as an anesthesiologist. This is not a question as such, but a comment. But I can, having worked in the operating room and seen patients who come with various stages of cancer, work closely with surgeons, I can only comment that this patient can be looked as a whole when there is a multidisciplinary approach from the time that the patient is diagnosed with cancer. It can never happen in the end. The conversation has to start early. I'm just adding on to what you're saying, but I've seen it so many times that then the surgeon really doesn't know how to approach this patient because conversations haven't happened earlier. And best outcome is if there is the multidisciplinary approach to every patient who is diagnosed with any, not just malignancy, but any life-threatening illness, which deems him or her necessary palliative care. So I think a multidisciplinary approach is the only way you could see the patient as a whole and then decide what to do when he's faced with the situation. Yeah.
Beautifully said. Thank you for the comment. I wholeheartedly agree. And I actually, for what it's worth, I taught this when I teach this when I work with residents and medical students in palliative care, and that is the investment up front in the time in those conversations, I've invariably seen pays dividends downstream, and it makes decision-making about all manner of things so much easier when that time and multiple team members are all there together talking. So thank you for that comment. Anything else? I apologize. I had to sort of run through the talk kind of quickly. Okay, if anyone is interested in poems or the cases or anything more, or the actual articles that I used to inform the talk today, I'd be glad to get you that afterwards. Okay, all right, thank you.
So our next presenter is Dr. Sanjay Awashti. He is an oncologist at Doctors Hospital and has been practicing oncology for more than 30 years. He received his medical degree from the University of Texas Southwestern Medical School, and he has been a tenured professor of oncology at several top medical schools, as well as the world-renowned Beckham Research Institute and City of Hope NCI designated Comprehensive Cancer Center in Los Angeles. He comes to us after serving most recently at the Cancer Center Director Division Chief of Hematology and Oncology at Texas Tech University. His research into the causes, prevention, and treatment of all types of cancer has been continuously funded for over 25 years through numerous prestigious grant awards from the National Cancer Institute, Department of Defense, and cancer foundations. And Dr. Sanjay Awashti is going to talk to us about the value of comfort, benefits of palliative support in oncology patients. Welcome, Dr. Awashti.
I'd like to thank Jasmine and Dr. Holliday. Hobday. Dr. Hobday and everyone at Jasmine for the invitation, and thank you. I chose this topic because of a attending I had as an oncology fellow. At the time that I trained, we had a total of 12 oncology medications, and our entire job was to take care of patients' pain and argue with surgeons to do palliative surgeries for the brain tumors and bladder tumors and so forth. I'd like to say to the previous presenters that thank you because you helped introduce some of the topics that I would like to address from an oncology standpoint, really starting off with saying that if you took the previous presentation and replaced surgeon with medical oncologist, you essentially have the exact same conversations, the exact same situations in medical oncology, everything from buy-in. You can give someone chemo, but then you have to know that they're bought in, because when their blood counts are 0, I've poisoned them. Okay, I have to wait until they're better. I have to support them. And if the patient and the family says in that middle that no more, I feel like I should have not done it to begin with. This is my 36th year of being a doctor and 31st year of being a medical oncologist. And I'm kind of ashamed to say maybe I've signed over 1,000 death certificates, sent more people to hospice than you could imagine, and did always feel like, hey, I'm abandoning this patient. This is a patient that I should take care of till the end. So that has a lot to do with some of the topics that I'm going to talk about, but I always like history. So I wanted to bring this up, and she sort of reminds me of Dr. Hobday. She's our dame of palliative care. So this is Dame Cecily Marie Strode Saunders. She was both a nurse and a physician, and founded the St. Christopher's Hospice in South London, opened in 1967. Interestingly, the American Society of Clinical Oncology was founded in 1968. At this time, in 1967, There were a total of 3 chemotherapy drugs. Interestingly, they're still in use. And interestingly, the most common one, which is called adriamycin, was invented in 1967. One of her favorite sayings, I love this. The reason I put her up is because she was one of the first physicians that we talked about in oncology. She's mentioned in the DeVita's textbook of oncology in the 2nd edition that I've trained on. So it says, it appears that many patients feel deserted by their doctors at the end. Ideally, the doctor should remain at the center of a team who work together to relieve where they cannot heal, to keep the patient's own struggle within his compass, and to bring hope and consolation to the end. This view, I think, evolved into what she eventually made palliative care. So I think these are what I call Cecily's pearls. I'm going to step down because I have bad eyes and I don't have anything to read with over here. So I'm going to just stand over here and talk. There's no such thing as intractable pain, only intractable doctors. Okay, that is, the pain can be relieved. Dying people need dignity, compassion, and respect. I think this is the most important thing that she said, and the most important principle of not really just palliative care, but it should be the most important principle in medicine. So total pain, physical, emotional, social, spiritual, and dimension of distress was a phrase I think that she actually coined, and is the principle of palliative care at the moment, and hopefully will continue to be that way. The effective pain control is always possible, thus euthanasia is not needed. I think this is also a key part of what doctors struggle with. In the end, as a medical oncologist, we hear very often, you know, doctor, do something, I just want to die. Okay, and that very often is actually surprisingly uncommon, because life is precious. You know, those people that are 70 years old and then they've tell that you have a 50% chance of surviving 5 years. That's not too far off from their normal survival, actually, if they didn't have cancer. So that you have to remind them that you are 70, but life is precious. When you're 85 and you want one more day, remember that for a 1-year-old who's going to live to 100, loss of 1 day means nothing. Loss of 1 year means very little. To someone that is 85, who's expected to live to 87, a loss of 2 months means a lot. It means the difference between a high school graduation So constant pain needs constant control, and dying people should never wait until their painkillers have worn off to receive their next dose. And she basically wanted to debunk the idea that opiates were addictive in cancer and dying patients. And most importantly, I think what I like is she abolished visiting hours, because visiting hours, she thought, was just an excuse for having non-visiting hours. So, but I think that the gem that she came up with beyond the pearls was rigorous scientific methodologies required for devising optimal palliative treatments. So there's some interesting conclusions that have risen from such rigorous studies, many of them that have been mentioned in the previous talk. The common wisdom of home-based comfort is far from universal. 31 to 87% of people, look at the broad range, okay, preferred death at home, okay? That is that we always say, well, once you'd rather die at home, there are many people that would prefer to die in a hospice or in a hospital or not to die at all. That's difficult. There is a medication for that. It stops aging, but the caveat is you have to have taken it yesterday. Today doesn't work. The interesting conclusion from another rigorous study, traditional methods of clinical assessment frequently miss many target symptoms for palliative care management. Patients differ substantially from their from their physicians with regard to factors and priorities that impacted treatment decisions. And a good example of that is a study in which they examined, they studied patients with inoperable lung cancer. And there was a set of symptoms that people came up with that was their list, the physician's list. And it was amazing how many of those symptoms were really not the patient's concern at all. There's a big discordance between patient-reported and clinician documented symptom. There's a good concordance with pain, but other symptoms, the concordance rate can be as little as 2%. And many of those symptoms are the ones that were mentioned in the talks before. The discordance in turn is associated with the patient's distress and poor quality of life. And this is a job that I see here Jasmine doing in an amazing way. Interesting conclusions of another rigorous study, goal or ratings that are used. Often these ratings are used by insurance companies actually to decide whether a doctor will be paid for a palliative surgery or even palliative chemotherapy. What's important in aggregate remains relatively stable, but patients' ranking of the most important goals and burden symptoms change over time. Today, they want chemotherapy. Tomorrow, they want pain control. The day after that, they want to know when they can get out of the hospital. And the day after that, they want to know when they can drive. Okay, only 29% of terminally ill patients who reported pain desired additional analgesic therapy. That does that surprise anyone? They'll tell you they have pain because that someone is listening to me. I have pain, okay? But this study showed, I mean, this is a convincing study of almost 1,000 patients, okay, in which it was, the patient said, no, I don't want any more pain treatment. Okay, and if you don't listen to them, then you'll more than likely, oh, you have pain, here, take another pill, prescribe another one. Oncologists may alter treatment decisions, experience an overwhelming sense of responsibility, guilty, distance themselves or withdraw themselves from both the patients and their families or loved one as the patient gets closer to death. No, not guilty. This is unusual for oncologists. This particular study was a very small study, and I think it was flawed. I don't think it's all that rigorous, but it does happen. There are instances where the treatment decisions are made by oncologists really based on what they believe rather than what the patient believes. And they really, most of the time, to make a decision to send a patient that you've been treating for years. And I've had probably over 100 different partners in different practices in oncology. It's like, it's like pulling teeth to say to them that, hey, this patient needs to go to hospice now. But Mrs. So-and-so, I've taken care of her for, what are they going to do? Who are they going to call? And it's amazing that when the patient does get into hospice, They're so satisfied that this doctor is taking care of them. So in a study of Medicare patients, individual physician characteristics, this is cool. Individual physician characteristics, rather than the age of the patient's medical comorbidity, age, race, or sex, had the strongest predictive value of the type of end-of-life care that they got. Okay, guilty. That is that this is an issue. A doctor who has dealt with no death in the family, his own family, who has dealt with no family histories of cancer, who has dealt with no personal illnesses, who has a one or another spiritual or religious belief from anything from heaven and earth to death, that affects whether a patient goes into hospice versus intensive care. And this is a believable study. 32% of patients received care that was not congruent with their preferences. Interesting, right? And this is not just the medical oncologist, okay? This is all patients, okay? 32% of everybody that goes to the doctor and asks for something walks away, okay, with care that they didn't really want. That is 32% of patients get care that they never asked for. And perception, and this I think the focus of both talks previously, is that when we assess what a patient needs, we have to realize that there is no box that everyone fits into. Perception of discomfort is highly individualized. And I wanted to just remind these diseases, and my wife warned me that don't be too statisticky in your presentations, because I tend to be that way, and I think someone else told her not to do that, but I wanted these numbers up there anyways. First, to demonstrate that you can make a table that says virtually nothing, because you have, I don't know how to turn on that, because you have ranges like this, okay? But notice the same diseases that were mentioned in the previous talk: fatigue, tiredness, weakness, cancer, COPD, heart failure, kidney failure. Here you can't tell. And the worst thing is that there are no studies on this. No good studies reported. Okay. But if you look across the board, you can see that there are very few symptoms that are, if you just take an average down the line. Okay, these are results from over 150,000 patients from a number of different studies, a meta-analysis. If you look at these numbers and draw averages down the line, you know why palliative care is important, and it's not just important in oncology. So the palliative care oncology was all we had when I trained. And then it went away because we were able to treat and cure testicular cancer for the first time. It was 100% lethal disease, and it suddenly went from 100% to 5% almost overnight with one drug. And it's amazing, you know, you can buy a gold ring or you can buy a platinum ring, and people had tried gold salts for cancer and never worked. But when they tried a platinum salt, 95% cure rate for testis cancer. And suddenly the emphasis on palliative care oncology just went away. Everyone wanted to do another chemotherapy and another type of treatment. And there were so many rationale for giving the next thing and the next thing. When I used to look at survival curves, and we used to have the thumbnail test, you know, if you can put your thumbnail between the survival test and with and without treatment, then it might be worthwhile. If you can't get your thumbnail between that curve, then yeah, I don't know whether it's worthwhile. But these are the principles that are currently taught to the medical oncologists for the past roughly 14 years. Palliative care oncology has been around, and fellows that now train in oncology, they train in these, and they're surprisingly similar to what is the original palliative care directive, which is it prevents and relieves suffering, supports the quality of life for patients and their families, relieves suffering in all stages of disease, not just end of life, should be provided along the curative or life-prolonging treatments, and palliative care also extends to the family's bereavement. When we say, here, so relieve suffering at all stages of disease, and my wife mentioned earlier that cancer survival starts on the day of diagnosis. Why is that? Because you survived long enough to be diagnosed. Okay, because if you had never gotten yourself diagnosed, they would have found it at your autopsy, if that was done. Okay, so the principles are exactly the same: symptom management, goals of care, values and preferences. And here the word values is very important, and I'll come back to that. Consistent and sustained communication, psychosocial, spiritual, and practical support, and coordination of care across sites. There was one study that was done in a company called Texas Oncology that I was a part of. It was a private practice oncology group, and they looked at what percentage of oncology patients left a oncologist after their cancer was cured at 10 years. Take a guess what it was. That they didn't come back and see the oncologist again. 5%, 10%, 80%. The vast majority of patients still keep coming back because that's the one doctor that actually treated them that actually listened to these things. And if you don't incorporate these same palliative principles that Jasmine uses in oncology, then you're doing your patient a big disservice, and 80% of them would not stay. So these are the categories of treatment for pain and cancer. It's amazing. There's so many things, most of them that have been mentioned. But if you look at this, the WHO ladder, there's only 3. There's there's non-opioid, opioid, and the non-traditional. Okay, and my approach is a little bit different. My approach really is that is based on what we were taught by animal studies, actually, in medical school. That the pain relief value of Tylenol in an animal in an objective study cannot be beat by codeine or hydrocodone, and barely beat by morphine. Okay. In patients, maybe it's the mental effects that occur with these medications that have an effect. These other therapeutic modalities are probably more important, and one of the underused ones are the interventional pain treatments. If the pain, I hurt here, I keep hurting here, it's in my rib, okay? Take morphine, take MS Contin. No, we'll put a patch on you. Heck, we'll fill you up with Neurontin, and then we'll give you an antidepressant. And the patient they've lost their mind. They can't use their bowels. They have no appetite. They're nauseous all the time. And everyone that looks at them and they say, well, you're addicted. We'll just stop your medicine. Of course, when it's stopped, if you ever give Narcan to a patient who has had morphine you will see what addiction really is and what happens when you just run out of medications. Has anyone given the drug Narcan to a patient before? And what happens if they're really in pain when you give it to them? Okay, that's pregnancy pain. There's no other, way to describe it. Okay, but that same patient, they come in and I take a 14 cc syringe or a 14 gauge syringe. I inject lidocaine into that area just above. And the patient walks out 5 minutes later. Okay, they don't have pain. Okay, and they come back and say, well, it only lasted for, an hour. Next time bupivacaine, and next time to the anesthesiologist who cuts that nerve, and the pain is not there anymore. They don't have any of those other symptoms. So it's very important to do those things, neural blockades, injection therapies, implant therapies. You can implant continuous infusions of narcotics in devices that are adjacent to your spine or in many other places, so that we have to think beyond just these pain medications that are oral. We have to really think about things like massage. And it's amazing, acupuncture. How many of you believe in acupuncture? Why? Have you had it? Okay, so I've never had it, and I believe in it. You know why? Because when my thumb hurts, okay, if I push right here on that nerve just below it, it's hurting. Okay, that's what acupuncture is based on. It's based on a real physiological principle, and it works. You should use it. Unfortunately, another one that's not in there is chiropractic. Okay, I've had patients who had intractable vomiting. Nothing worked. I asked a friend chiropractor. He says, "Oh, the C2 is out. Crack. No more nausea." Okay, so we have to think beyond the minimal. Of course, the psychological and the psychosocial forms of treatment are, again, that mind-body connection. It's not the body that controls the mind. It's the mind that controls the body, so that that perception of pain is the key. So, I had to put in something that my wife did not want in this presentation. So I said, I'm going to put in a little math. Okay. So this term, quality of life, I love this term because in math, I'm sort of a mathematician. So of always means multiply, right? So quality of life means quality times life. And interestingly, if you take that equation and you make either quality 0 or time or life 0, the answer is the same. Okay, 0. I guess that makes sense. But what if we look at it another way? We say quality per longevity. Okay. Here, when your quality becomes 0, of course, your quality of life becomes 0. You're alive, but you have no quality of life. When you have the denominator, the longevity 0, by mathematical definition, it's not defined anymore. Unfortunately, neither one of these are easy to quantify. And the reason isn't because we don't have, ratings and charts and so forth to do it. The reason is that we don't perceive in a linear fashion, and we don't perceive in a discrete fashion. Okay, all of our perceptions are really sort of Newtonian. Okay, and Sir Isaac Newton made this nice little curve like this. How many of you know what that means? What does it say? Okay, so what it means is in today's day and date, what it means is add all the numbers up. In the old days, it used to mean integrate. But now you have a Microsoft Excel spreadsheet, you have 10,000 numbers, you add them all up, divide by the total number of rows, and you've integrated. Okay, or don't divide by the rows and you've integrated, divide by the rows and you've had differential calculus done. Okay, but we perceive quality and life as an integral of quality as a function of life, and life as a function of quality. And these things at the top and the bottom means you begin right here and you add everything all the way to the end of life, and you add all those things together. And then you take your life and you quantify it by amount of pleasure each time, how many times you had sex in the 10 years that you were given to live. And then you take the ratio of it, and that's the nice quality of life. And interestingly, you can actually do this in measurement of quality of life. So palliative care is very complicated. There's a lot of math in it. There's all kinds of tables that we can't read, but not really. We have to think back to kindergarten and our teachers. What were we taught? How many of you remember your teacher saying, honestly, pay attention, okay? That's what the patient is telling the doctor, okay? The patient is sitting there and talking to you, and you're going, okay. We're forced to do that now, unfortunately. But pay attention to what the patient is saying, because that's what all of those previous assessments of a patient's quality of life indicators are. If you actually pay attention to what you're supposed to be doing when you do a history and physical examination, then you'd often do not need a lot of guidelines or even often CMEs. See. Don't just look. I forgot to put that in there. Listen, don't just hear, and always do it with your heart. Okay, that is that you sit there at the patient and say, man, I would feel terrible if I was sitting over here. And an example from today, patient waits for an hour and a half. And if I had sat there, you know, I would be really sort of pissed when I came up to talk to the patient. But often when the patient says, yeah, I'm having a little bit of pain over here and so forth, you're not listening, because what they're saying is that I have pain and I haven't been able to have a bowel movement, and your head is going, oh, pain, bowel movement. What this patient is telling you, if you listen carefully, is that their spine tumor is impinging on their spinal cord, and they're starting to go and they become paralyzed. Okay, you have to listen. What happens when you listen? Well, you get a lot of information in your head. You do it with your heart, you do it with a kind heart, doesn't matter, because you cannot interpret it, because you never actually had the learning to interpret what that means. And when you learn, make sure you write it down. Okay, because someday you're going to go back and look and you're going to say, oops, I made a mistake. I didn't even write that one down way back then. And in a way, these are all admissions of guilt, but use your head, apply your learning. The key word, apply. You learn, you wrote it, you applied it, and apply means connect the dots. And if you're still puzzled, go learn some more. If you make mistakes, forgive yourself and really accept the forgiveness from your patients. If you don't know the cause of the problem, it's unlikely that you can fix it. And this is the future of oncology. This is the past of oncology, and this is the future of oncology, because when we gave medications, we gave radiation to acne because we didn't know the cause of acne. Those people developed thyroid cancer 20 years later, okay? You didn't know what caused it. Today, 10 years ago, if you had thyroid cancer, you really didn't have any good way of treating it. You give drugs that radioactive iodine, it worked or it didn't. If it didn't work, you had nothing else. Today, you know what causes it. You know there's a gene called RET that's mutated, and if you give a drug that's targeting that one gene, one abnormal gene, these people are alive 10 years later and they have no thyroid cancer. Melanoma patients, when I started, the first patient I ever sent to hospice was a man who had melanoma that extended from his fingertip to his chest. And these were not just little bits of melanoma, these are large whelps of melanoma. And my attending doctor, Dr. Hout, was giving him a drug called interferon as an infusion. And I would walk in the room and he was chilling. And I would ask him, well, first year resident. My time is okay. Okay, so my first year resident says, I'm a first year resident. I walk in there and I am just horrified. I said, what is this oncologist doing? And I ask the patient at that time, he can't answer anything. I come back 2 hours later, he's not chilling anymore, but he doesn't want to stop the treatment. He says, well, that one right there got smaller. Okay, and I'm looking at his entire chest. I swear at least 20 pounds of melanoma on him. Okay. We were giving a drug that we didn't know what the disease, what the cause of the disease was. Now we know it's a single mutation. It's called a gene called BRAF. And if it's mutated in one spot, then all you have to do is to give one pill and it will go away. And it will be there. It will not be there 10 years later. And now there are over 300 of these genes and over 270 approved treatments for almost every one of these genes, that now, once you know the cause of the problem, go back and learn what it is, you apply your learning, and then you can fix it. But in the end, you really have to take all of this and act, because acting on what you learn is the hardest part. It's a hard part in oncology. It's a really hard part in any part of medicine. Surgery is a particularly bad one, because there, when you've made that incision, you've made your mind up there. If the patient is not to be DNR now, okay, it's to be DNR now, it's, you're thinking, oh no, okay. Or that infusion of chemotherapy is going and you get the result back. And you say, that maybe that's not the one that I should have given, but you gave it not for your interest, okay? You gave it for the patient's interest. You did it for those patients' interests. And the reason I put this down here, those cannot remember the past are condemned to repeat it, because your teachers told you most of this stuff when you were in kindergarten. So when you do act, this is a principle that I actually remind myself of every day in a small poem that I read to myself. I won't read it right now. But perform all actions with passion, heart, mind, spirit, and soul according to clear goals and plans. You need to know what you're going to do today and how you're going to do it. And interestingly, this is translated in Hindi in Sanskrit into one word. That's what that word means, okay? And in Hindi, we just call it Kam. And some of the computer programmers that invented .com, okay, C-O-M, that's what that means. That's what they wrote it as. There's 7 principles of effective action in oncology and palliative care, and those are: number 1. Which one of you thinks that this one is number 1? Or this must be number 1, right? Oh, no, definitely this one, because we know values, because you need to know what you value, okay? What is a value? Well, $1 is a value, okay? What you learn to one person, what you learn that day might be the value, okay? It might be your value, okay? They say in large corporations that you can have people that are aligned in their thinking and their missions and their strategy and their tactics, but guess what? There's only one that predicts success of that organization, which is alignment of values. When the oncologist value and the palliative care value and the surgical value, when they align, then you know that you can do things together that will help you reach your vision. Vision is what you can see. A patient, I have the vision that the patient will walk out of this hospital after having been an intubator on chemotherapy. The mission is what I have to do to get there. Strategy is the sequence of events that I may have to take, or different sequences that I could take. The tactics are the different drugs, and the plan are the chemotherapy orders that I write, or the hospice orders that are written, or that place where the Jasmine nurses famously gather every day. Okay, I went there and visited. They discuss everyone. Okay, they have a plan. They have a very clear plan, and then they take action. And then you reassess and you admit mistakes, you correct your plans and be persistent. And these are the same things that are just as important in medicine and in oncology and in surgery and also in palliative medicine. And almost every slide that I've said before this is based on this. The only thing we have to fear is fear itself. Okay. This is Franklin Delano Roosevelt. The patient is afraid of the diagnosis. The doctor is afraid of telling him that you only have a month to live. The insurance company is afraid that I'm going to tell them that there is a palliative surgery involved and there is $100,000 a month drug that can cure the patient. Because in the end, we can discuss palliative surgery all we want. It's Brit K that's going to decide whether you can do it or not. And why are you fearing? Look at this. This is actually true. And you know why? So we designed it this way, okay? This is what the definitions are. Stage one, basically stage one of a cancer has a 90 to 100% cure. Some of them are a little higher, some of them are a little bit lower, but in that range. Stage two generally means a big drop. Stage three means a really big drop. And then stage four, and this is the reason for mindfulness, okay? You are mindful of your own body, you will recognize your disease, you will be able to catch it at stage one. And what will happen? Well, cancer is a disease of the aged. Look at this. If you actually integrate this curve, you'll see that almost everyone is getting cancer when they're older, okay? If you superimpose the expectancy, life expectancy over here, the life expectancy of an 85-year-old is relatively short even now. But even 70-year-olds don't have a very long life expectancy if they've been smoking, drinking, and doing all kinds of other things, as this here shows in terms of cancer-causing substances. The list is too small. Some of them are covered actually well by the 7 deadly sins, but I won't get into that. And inflammation. And guess what? The risk of cancer is decreasing every year, okay, since 1991. I became an oncologist, fortunately, in 1991. So good choice. 32%, and this is applicable to all cancers, nearly all cancers in both women and men. Unfortunately, the intractable problems of smoking and drinking and alcohol use and things that are just bad luck that you had nothing but nothing to do with. And this is the total number of anti-cancer drugs approved by the Food and Drug Administration every year. Okay, you have to add them all up to know how many there are. But last year there were 57 approvals, or the year before last, I think unfortunately, you know, only a very few of these are actually new cancer drugs. People say, oh, there's all kinds of new cancer drugs. 10% are new. So I will stop there and if I have any time for questions, I can answer. Otherwise, I can answer later. And thank you so much for your attention.
Say thank you very much because you won't be here tomorrow and the other speakers will be here tomorrow, so they'll get their presents tomorrow.
Okay.
So we're
Well,
going to give that to you.
yes, thank
Sanjay,
you. I
and
feel
that's for you.
special. Thank you.
In the interest of time, again, we're going to let you guys actually have a break, but what we're going to do is take a 10-minute break. I encourage you to grab refreshments, stop at the booth really quickly, and then bring your food back in here, and we'll start back in 10 minutes, and we can eat while we listen and learn. Thanks. See you in a bit. Thank you. Come in. Hello. Thank you guys so much for grabbing your refreshments and coming back in. I'm going to hand it back over to Dr. Hopday so we can keep going.
So our next presenter is Dr. Kane. She is an MD in palliative care and hospital medicine physician at Massachusetts General Hospital and an instructor in medicine at Harvard Medical School in Boston, Massachusetts. She completed her medical school and internal medicine residency at Northwestern University Feinberg School of Medicine in Chicago and a palliative care fellowship through the Harvard Interprofessional Palliative Care Fellowship Program in Boston. As a native of Senegal, she is deeply passionate about expanding access to affordable and high-quality palliative care in Senegal and Francophone Africa. She currently resides in Boston, but travels frequently to Senegal to visit family and collaborate with colleagues in Dakar. And she is going to talk to us about beyond end-of-life care, palliative care as a pathway to optimizing chronic illness. So welcome to Dr. Kane. I said it wrong, didn't I? Dr. Khan.
We're going to see how ambidextrous I am. Going to be manipulating the laptop and the clicker. Thank you for this kind introduction. I'd like to thank Jasmine for the invitation. And I'd like to thank Felicia for her tireless coordination to get us here today. And a shout out to Crystal, to Dr. Natalie Sharp, and everybody in the office for the warm welcome. My name is Hadi. Oops. There we go. My name is Hadi Khan. I am an internist and a palliative care physician in Boston. I come via Senegal. I moved to the US when I was quite young with the notion that I was going to be there for 2 years for an international baccalaureate high school and then return home to work as a physician. 30 years later, I'm still trying to make my way back. But I tell you this because what brought me to palliative care is probably what I'm going to be talking about in terms of why I think integration of palliative care is very important. When I finished my internal medicine residency in Chicago, I was given the opportunity to work as a hospitalist, meaning an inpatient medical physician taking care of oncology patients. So I was not oncology trained, but we had the opportunity of devoting about 50% of our time taking care of exclusively oncology patients. So you could imagine I was at the front line of basically how integral palliative care is to the care of patients with cancer. However, as an internist, it didn't dawn on me that that palliative care could also be integral to the care of patients with chronic non-cancer illness. And the data that I'm going to be presenting today hopefully will allow us to expand our scope of discussion. And I think our friend, the anesthesiologist, mentioned it earlier, that if we can integrate palliative care early in the care of chronic illness, that we can optimize healthcare outcomes. I don't have any financial disclosures pertaining to this presentation. I'd like to start, if it's possible, by listening to the story of Mary. I'm not sure if we're able to click on it from the laptop. It's an audio. This is not an ad, but it's from the GetPal Care website.
Mary Tibbetts knows firsthand what it's like to care for an aging parent. She is the primary caregiver of Mary Nolan, her 88-year-old mother who has diabetes, but enjoyed an independent lifestyle.
88 years old, totally and completely independent, except she didn't drive any longer, but she lives on her own, paid her own bills, ordered her own medication, sorted her medication every week, cooked her own food, went out and played bingo, crocheted, did everything, lived totally independent, got up and around.
But after a rehab visit at the hospital to improve her blood flow, Mary's mother went into congestive heart failure and her quality of life quickly deteriorated.
My mother went in on December 3rd to the hospital, which was just a couple days after Thanksgiving. And the Tuesday before Thanksgiving, my mother was at my house with my son, and she was helping us peel 26 pounds of apples to make applesauce. She's Russian. She's very strong. To see her down like this was really, really hard.
Mary's mother was in and out of the hospital and rehab facilities, but her quality of life wasn't improving. She was still incredibly weak, and of the nearly 20 doctors that Mary's mother saw, none thought she would ever be ambulatory again. Frustrated and confused from trying to navigate her mother's care, Mary turned to palliative care.
Right. This story is very familiar to all of us. And for those of us who practice in the US, the intricacies of the healthcare system really illustrates this story. So with the story of Mary in mind, I'm hoping over the next few minutes to articulate a clear definition and an up-to-date definition of palliative care, which is going to be a lot of repetition, to be honest. I think the lecturers before me set it up quite nicely, so we might be able to really do this first objective. I'd like to demonstrate to you how palliative care can be beneficial for patients with serious illness, specifically patients with non-cancer illness, and then to describe some of the evidence bases we have for the positive impact of palliative care integration on the care of patients with okay. All know it by now, but I'd like to highlight a few things with this World Health Organization definition of palliative care. Can you hear me? Perfect. With this World Health Organization up-to-date definition of palliative care, I'd like to highlight that one, the person we're taking care of is not just the patient in front of us, but it's an entire unit. And my colleagues have mentioned it before. It's the patient, it's their loved ones, it's their informal caregivers. It's everybody who really is impacted by the stress of illness for the patient. We have a responsibility towards them. We may not be treating their illness, but we are treating the impact of our patient's illness on the unit. The second point is that suffering is what we're targeting. Preventing suffering, relieving suffering, mitigating suffering is at the heart of what palliative care is about. And the third thing is that this suffering is multidimensional. And I think my colleagues have mentioned it earlier. Suffering is physical, it's emotional, it's spiritual, it's psychosocial, and all those domains are for us to target. And that is our responsibility. And I wanted to mention, if you notice, we're talking about patients with life-threatening illness. Sometimes we say serious illness. We're used to mention terminal illness, but with the advances of medicine now, we have turned these terminal illnesses into chronic illnesses that patients live with for years. So it is our responsibility, while we've added years to their life, thank you for that, that we also take care of the impact of not only the disease, but the treatments that we are giving to them. And after declaring basically in 2002 that palliative care access is a human right in 2002, the World Health Assembly in 2014 passed a resolution that determined that it was the duty of governments to strengthen palliative care in their health system. The words it used specifically was that palliative care is the ethical responsibility of governments. It also says that healthcare professionals have the ethical duty, again, the word ethical, to relieve pain and suffering. So what is in this sauce that we're talking about? For most of you who are palliative care providers, or even not providers, I think we're pretty familiar with it now, but I'd like to just mention a couple of things that are quite distinct in palliative care that really is sort of the ingredient of why we are able to relieve suffering. First, palliative care is delivered by a multidisciplinary team. We've already talked about that. It's different providers coming from different perspectives. It's not just the medical and nursing perspective. It's the psychospiritual perspective. It's the integrative therapy perspective. It's the dietary perspective. It's understanding all of those things that come together to impact the patient and their experience of illness. And palliative care also really strives on working in partnership with the patients and specifically with their existing physicians. Unless it is already agreed upon, we don't come over we don't come in to take over the care of the patient. We're here to be an extra layer of support for the patients. And as we understand, sort of severing that therapeutic relationship that patients already have with their existing clinicians can be quite traumatic. So we do not want to ever be the thing that replaces this longstanding relationship, but just an added layer of support. And through this multidisciplinary approach and partnership, we're able to provide simple and complex symptom management, ranging from refractory pain to simple insomnia, to fatigue, to cachexia. And we also provide psychosocial and spiritual support that's already been mentioned. And I might say that the same way the scalpel is the tool for the surgeon, communication is really the tool for palliative care clinicians. It's through communication that we're able to understand and explore for patients and families. This is kind of running away on its own. That we're able to understand for families and patients what really matters to them, to explore their goals and values, what quality of life means for them. And that time is not something that all of the providers already have. So we often hear providers say to us, what's the point of palliative care? I already do this. I talk to my patients. I know what their goals are. I treat their symptoms. What do I need you for? And I'll be able to show a little bit of data later on for why actually adding us to the care can be helpful. But what we can be helpful for is time. Time is of the essence, and we have time that we can focus on exploring some of these goals and values for the patients. I won't go through the history. My colleagues did it already, but this is just to mention that palliative care really is about reconciling medicine with its roots. I remember in 2015, after being about 8 years into my practice as a hospital medicine physician, that I wanted to do a palliative care fellowship. So I decided to go back for training. I was on a plane flying out west to interview for a palliative care fellowship. And this lady was sitting next to me, you know, playing small chit chat. We started talking, where are you going? What are you doing? I'm going to go interview for palliative care. Palliative care, what is that? I gave her the definition I gave you with maybe a little bit simpler terms. She turned to me, she said, well, isn't that just medicine? Yes, it is just medicine, but it is also more than medicine. So she basically was reminding us what all of us have already said and have known really deeply, is that this is one way of really reconciling medicine. The advances we've had in technology are wonderful. It is great that we can prolong life. It is great that we can cure disease now, but let's not lose that human side of medicine. And I also wanted to show this slide just to mention, for a lot of people, some of the barrier to palliative care is that they think palliative care is synonymous with hospice care and end of life. Hospice care and end of life care are critical parts of what palliative care does, but they are not the only thing that palliative care does. And we have mentioned it earlier that really good palliative care is integrated early on in the illness and plays a role throughout the trajectory, including after death, by providing care, bereavement care for the patient's loved ones. Repetition is key. This is just a summary of what palliative care is before we go on to the evidence that we have. But I wanted to highlight here what palliative care is not. It is not synonymous, again, with hospice or end of life care. It's more than that. It is not about giving up on your patients. It is not supposed to take over for the opportunity of getting curative care. If your patient wants to get chemotherapy, let's do it. If they want to get palliative surgery because that's going to improve their quality of life, that should not be a barrier to also getting palliative care. And also, palliative care is not an attempt to hasten death. We're not trying to just make everybody just decide that they want to focus on comfort only and not disease targeted therapy. And one last thing, because there's a lot of data that palliative care actually does save costs. It is not meant to to just sort of contain medical costs, even though that is one of the positive byproducts of palliative care integration. So you say to me, this all sounds nice. I know it works. For a lot of us who already practice palliative care, we know it works. But for a lot of other people who are not in the field, they're like, where's the proof, right? My cardiology friends want me to show them the data. Our oncologist friend went through that phase about 10, 20 years ago, where we were able to then come up with some data to convince them. And this is probably one of the studies. I had to step out for a second, so forgive me if you've already mentioned this study earlier. my colleague who presented with about oncology and palliative care. But this is a study by Dr. Jennifer Temmel, who's at our institution at MGH. She partnered with our palliative care program, J. Andy Billings, Vicky Jackson, and decided that she was going to convince her palliative care colleagues that introducing palliative care was actually beneficial. It wasn't just good talk, because she was, again, hearing the same thing. I already do this. We do this for our patients. What is the benefit? So she randomized 151 patients with not metastatic non-small cell lung cancer at the time of diagnosis. And one group got their usual oncology care. The other group got oncology care. Is it possible for it to not advance on its own? Or am I, yeah, okay, sorry. But basically they randomized them, and the group that got oncology care plus palliative care was able to get monthly visits from a palliative care clinician to address the palliative care domains, whether it's advanced care planning or suffering from a multifaceted perspective. And what they measured at the end was quality of life, mood, and end-of-life outcomes. It doesn't get better than this, right? We say randomized controlled trials are sort of the gold standard for really proving whether something works or not. And the proof is in the pudding. The group that got early palliative care integration actually ended up with improved quality of life. They had better, they had less depression. They even had less anxiety. And for some reason, they actually survived more. They lived a little bit longer, a little less than 3 months. I think the jury's out there about why that happened, kind of sort of debating why that happened, but that was what the data showed. And also it was noted that the people who got early integration of palliative care were less likely to get very aggressive care at the end of life, getting chemotherapy right up to the end, or spending time at home. They were able to spend time at home, and also enroll in hospice earlier than they would have. And in that study, they were able to demonstrate that those were goal congruent care. That's the most important piece. We can skip this graph. It is just sort of to explain how that study and our evolving understanding of palliative care has really made us move palliative care upstream, and to not just see it as something that we do at end of life. So this was great. It allowed our oncology friends to say, this is wonderful. Actually, it's not just talk, it does work. So over the following 10 years or 15 years, we started having a lot of integration of palliative care in oncology. All the cancer centers were required to have some form of palliative care. Palliative care clinics were embedded in oncology, and we saw a lot of improvement with our patients. We were, however, still getting a little bit of resistance from our liquid tumor oncologists, who are like, well, wait a second, it's a little bit different for my patients. My patients with multiple myeloma or lymphoma, my patients who just had a transplant, their prognosis is not that certain. It's not the same as stage 4 solid tumors. So I worry that you're going to bring in palliative care, and they're going to think that everybody's dying, and they're going to convince everybody to just give up, quote unquote, and go to hospice. So Arij Al-Jawahiri is a leukemia specialist at our cancer center. She tried to replicate a little bit of what Dr. Temmel did with our palliative care group. So they've been doing studies since about the early 2010s, but most recently, this one that they published showed that for patients with acute myelogenous leukemia who were randomized to either palliative care, to oncology care only, or palliative care integration. And in this case, palliative care integration meant that they would see a palliative care physician at least twice a week when they were admitted to the hospital. And every time they were readmitted, they would also see a palliative care physician at least twice a week. Excuse me, the slides have a mind of their own. But the bottom line is it showed that there was significant improvement in psychological distress, in quality of life, and end-of-life care, to the point that the authors are stipulating, along with all of the body of data that we have now, that palliative care should really be considered a new standard of care for this patient population. So, okay, we know palliative care helps with cancer patients. That's what I understood as well when I was taking care of cancer patients. But I, the internist, couldn't actually put 2 and 2 together, that yes, it could be as helpful. Yes, I was calling palliative care for my CHF dementia patients, but I really wasn't as consistent about it as I was with my cancer patients. So what Dr. Quinn, his group in Canada in 2021 tried to understand sort of how palliative care is delivered for cancer care and non-cancer care. So they compared the last year of life of patients who either had cancer or patients who had a non-cancer illness, and all of those patients passed away. This was a cohort of about over 145,000 patients. And what they found was that the patients who had cancer tended to be younger. They tended to have less comorbidities. They tended to have less symptoms. They tended to be hospitalized less, but they received much more palliative care. They were referred much earlier, and they had more consistent palliative care than the non-cancer patients, your CHF, COPD, and stage renal disease, who actually had a higher symptom burden, at times were older and had more comorbidities. And the question is, why is this happening? Well, they're stipulated that, again, with the advances we've had with integrating palliative care in oncology, it was just very easy for some of those patients who were in oncology centers, that they were very easily referred, regardless of the symptom burden or where they were in their illness, because we know integrating it early helped. And we hadn't made as much movement in terms of integrating palliative care in non-cancer illness, but they're stipulating that there's also something else to it, that maybe there is a deficit of knowledge for providers about how palliative care can be helpful for non-cancer patients. I just informed you that 7 years ago, I, as an internist, didn't really appreciate how much palliative care could be helpful for non-cancer patients. And there's also a variability in terms of how providers are really able to assess the impact of the illness on their patients' quality of life. You can imagine with cancer, and the reason why is here with cancer, you can imagine the trajectory is a little bit more predictable when you're talking about end stage cancer. In red, you have your organ failures, CHF, COPD, end stage liver disease. In green, you have dementia, frailty. These are a little bit less predictable. We know eventually life expectancy is short, but it's a seesaw. There are these moments you can imagine when patients are seen in the hospital with their exacerbations and they're in that valley. If you're not familiar with the illness course, you might think that this is sort of their end stage process, but it is just part of the sort of natural decline. And this, I think, is what makes providers fearful, that they don't really know when it is appropriate to refer. Is it too early? Am I sort of not giving them a chance? That could be a complicated question, but not really. If we stipulate that anybody who has a high symptom burden, whose illness experience is causing tremendous stress on them and their loved ones, that palliative care is appropriate to refer to them at any point in the illness. So that kind of takes away that argument about, I'm not quite sure when to refer or not. And Dr. Mounsey here did some surveys with patients and providers to figure out what some of those barriers were to late referral to palliative care for patients with non-cancer chronic illness. And it ran the gamut anywhere from people who were just uncomfortable talking about palliative care, again, because they associated with strictly end-of-life care or hospice. For cultural reasons, it was a little bit difficult to talk about death and dying. Some people felt that there were unclear triggers for referral. We talked about it for some of the providers. There is a lack of recognition, as we talked about. I think this one is a little bit, is not well appreciated, that we take care of our patients. We know that CHF or COPD can have a high symptom burden. We know that they have a difficulty breathing. Now they're on oxygen, they're at home. We can imagine that it's creating a lot of impact on their quality of life, but we tend to not appreciate to what extent, because we're so focused on trying to modify the course of the disease itself. So that alone is sort of a barrier for late referral for non-malignant disease. So following what the oncology people did with proving that early integration of palliative care can work, CHF, end-stage renal disease, liver disease became sort of these areas where at many different centers in the US, people were doing studies to try to figure out what's the impact of palliative care in these illnesses and how early can we integrate them. The data is still in its infancy, but I'd like to present just a couple of studies. First in the CHF world, which has probably made more progress than any of the other non-cancer illnesses. So in this wonderful study, there are many others, but this is the one good randomized controlled trial. It's called the Palliative Heart Failure Study. I'm sorry, this has a mind of its own. It's the Palliative Heart Failure Randomized Control trial. They basically randomized 150 patients to, again, usual heart failure care for advanced heart failure, or usual heart failure care plus palliative care. In this study, the intervention was that every time patients get admitted, a palliative care nurse practitioner would look at their case and assign a palliative care physician to go and see them. The palliative care physician would see them either in coordination, like simultaneously with the primary cardiology team, or they would be talking with the cardiology team to make sure that they were all on the same page. And what they addressed were really the impact of the illness on patients' quality of life using those multiple domains: physical, psychosocial, spiritual, and also making sure that advanced care planning was addressed. And what they found, and when they would discharge, also the nurse practitioner would make sure that in the outpatient setting that they also had the same palliative care follow-up. And what they found was that for the group that received palliative care, all right, just making sure that that's my stuff. Sorry, it's for anybody who's this is making busy. Okay, but for the group that received palliative care, again, they had better measures of quality of life. They had less anxiety and depression, and even increased spiritual well-being. And that has prompted the many societies, including the European Society of Cardiology, Heart Failure Association, the American College of Cardiology, Heart Failure, to say that palliative care should now be part of the standard of care for management of patients with advanced heart failure. Now, the question remains, how do we best do that? And we don't really have the answer yet. But Dio Cavalieratos here in 2017 did a review article where he tried to look at all of those studies integrating palliative care in heart failure management. And basically, things were in their infancy. There was not a lot of consensus, but what he could stipulate was that point number one, palliative care integration in the form of primary palliative care, meaning the cardiologist or the primary care physician themselves provided the palliative care, that was an easy thing to do and could be done at any point during the course of the patient's illness. And that specialist palliative care could be sought out, meaning referring patients to a palliative care specialist such as myself or Dr. Rosenberg, who went into fellowship. And that was probably most important when patients were really declining. So using those opportunities, those salient moments such as an exacerbation, an admission, as an opportunity to really refer to specialist palliative care, that might be one of the ways that we can actually integrate palliative care management. But to be honest, what I would like to say is I think the best palliative care is the palliative care you can give. The data I'm presenting is from North America, from Western Europe, but what really matters is what does palliative care look like in your local context? And you're doing that already. Jasmine is doing that. Jasmine knows best what palliative care on the Cayman Islands look like. Palliative care in the US looks like one certain thing. I think it's important for us to have an understanding of what are the domains that palliative care sort of covers, because obviously, unlike nephrology or cardiology, we don't have a name that can easily say what it is that we do. So I think it is important that those definitions I talked about, which sound very kind of sort of a little bit too vague. It is important that we really remember what those definitions are so we know we're providing palliative care. But when we are within those domains, the best palliative care is the one that you have the resources for, the one that you have the skills for, and the ones that you are integrating in your healthcare system such that it's actually going to lead to a culture change. So if you learn anything from this talk, it's going to be that palliative care integration early on is paramount. And two, you have to do it in your context and what makes sense for your context. Everybody wants to get on the bandwagon, thank God. COPD, we invited Dr. Iyer actually at our grand rounds. He gave a wonderful talk. He's a geriatrician pulmonologist actually, who's been really working on moving the needle on palliative care integration in COPD care. And he did this review article that was published in CHEST, which found that surprisingly, despite the significant symptom burden of COPD on patients, right? Breathlessness, social isolation related to just being tethered and homebound. And despite the fact that we know that there are simple, easy ways of integrating primary palliative care into the care of COPD patients, that COPD patients were not getting primary palliative care, that oftentimes when they got palliative care, it was really late in their course and it was really just for referral at end of life. So basically the culture change is going to be trying to recognize again that palliative care for this patient population is not just end of life care, and trying to figure out ways to move the needle upstream. So I think there are lots of studies underway that could be promising. End-stage renal disease probably has one of the highest symptom burdens than any of the non-malignant chronic illnesses. And this is just a quick rundown, and it's actually not exhaustive at all of the symptoms that patients on dialysis or advanced kidney disease experience. It's anywhere from fatigue, pain, itching, anxiety, depression, and then the impact, the stress on their caregivers and loved ones as well. And despite us knowing this, it is also known that a lot of patients with end-stage renal disease, whether they're on, whether they have patients with advanced kidney disease or end-stage renal disease who are on dialysis, that a lot of them do not have documented advanced care planning, that many of them have not seen palliative care, and many of them have not had actual psychosocial assessment for their patients. So there's a lot of flurry right now in the kidney world trying to integrate palliative care in the care of patients with advanced care disease and advanced kidney disease, and also to stress the importance of palliative care in kidney care is not just about stopping dialysis. A lot of people think when you call palliative care for a patient on dialysis, it's to try to convince them to stop dialysis. It is part of what can be appropriate at times. It can be what we allow and give patients permission to do, because that's what they want, but they've just felt uncomfortable saying it to their continuity physicians. But it is not what we are here for. We're here to explore what their goals are and figure out what matters. I'll skip this a little bit because Dr. Rosenberg is going to be talking about dementia tomorrow, but it's really to just recognize that dementia carries a very high burden of emotional stress on patients' caregivers, whether it's related to just the neuropsychiatric and behavioral symptoms that patients with dementia display, that patients who, caregivers of patients with dementia tend to have about 5 times as much depression as the general population. So there's a lot of work being done in the palliative care world right now around just sort of symptom management for patients with dementia, but specifically caregiver support. So there's some data that's going to be coming out pretty soon. And palliative care is very suited for really meeting the needs of some of the of our patients with dementia because of all of these domains that it addresses. Again, this is just highlighting that there's a lack of consensus on how to best do it. This is just one slide, and this slide illustrates sort of all of the gaping holes in our health system. I can speak for the US, but home care, which is probably the most important care that we can provide to sort of allow patients to really live well, is the one thing that we're lacking. And it's the same thing in palliative care delivery. Home-based palliative care is lacking. Usually it's either hospice or inpatient palliative care, or maybe in the clinic. So there are studies being done right now to figure out how to best integrate home-based palliative care. And by that, we mean a palliative care physician with somebody who's not on hospice, just going to their home, assessing their symptoms, coordinating care with their providers, supporting the family. We do it for dementia patients for 5 years, 6 years, 7 years even, and again, impacts quality of life. With all of that being said, it's really nice. Palliative care really does improve quality of life of patients and their loved ones. But the good thing is it doesn't increase cost. That is not why I'm recommending that we do it, but it's good to know that we're recommending something that can actually move the needle on really impacting outcomes for patients and their loved ones, yet it doesn't break the bank, and yet it doesn't take away resources from other things. If anything, it may be allowing us to sort of divert some of those resources that we're not using to improving the care that we provide patients. This used to be the graph that CAPC, the Center for Advancement of Palliative Care, used to tell us to show the C-suite whenever we wanted to convince them to fund a new palliative care program. But I think we don't even need this anymore. We've got plenty of data that it works. So let's go back to Mary, and we'll see if we can get to maybe about 2.5 minutes to see when palliative care was introduced for her. And apologies for the dancing slides there.
A week. And she was bedbound really at that point.
That's Dr. Leanne Yanni, a physician on Mary Nolan's palliative care team. Dr. Yanni and the other members of the team immediately met with Mary Nolan and her daughter to discuss their goals for her care.
When she was in a near crisis situation, we sat down at the bedside and we asked her some questions about how she viewed quality of life. So once we understood that, we could help navigate the interventions that were being suggested or the course of care that we should take to support that view of her quality of life.
For my mom, part of it was she needed her third blood transfusion. And it was, do we do this or don't we do this? And Dr. Yanni came in and wonderfully spent, time with my mother and with myself and with my brother on a conference call and didn't rush us and didn't tell us what we had to do or didn't have to do. She explained to us our options. And if it hadn't been for that last blood transfusion, my mother wouldn't have made it.
Mary's mother's health and quality of life both began to improve. But that's only part of the story. Palliative care treats seriously ill patients, but it also treats their families. Mary, struggling with caregiver burnout, needed support too. For Mary and her family, Dr. Yanni and the palliative care team made a significant impact on their quality of life.
They were doing what was necessary to help my mother and to help me and my brother and my husband and my kids. They helped. They had that piece of compassion. Dr. Yanni was probably one of the most compassionate people that I dealt with. And I think that was a big help and a big piece of it that made it a much better experience. The palliative piece kept me going as much as don't give up.
Palliative care brought a sense of comfort to her daughter, who was in a stage of very significant caregiver burnout, a very common scenario for children taking care of their parents or parents taking care of their children, depending on the situation. And with the support of a multidisciplinary team that included spiritual support and our psychosocial support through our team's social worker, she was able to express her own feelings about doing the best she could to take care of her mother's situation, as well as care for her own family and herself.
And how is Mary's mother doing today?
Having her in the palliative care and the fact that they were continuing to still do things to help mom played a part in the fact that my mother is still here with us today. Someone asked me how my mom is doing, and I said, well, take a look at this. Here we are having dinner at her apartment the other night with my 2 kids and my son-in-law. And she looked at the picture and she said, oh my God, look at your mother.
So the point of the story is not what intervention Mary ended up getting. Yes, she got a blood transfusion, which, paradoxically, you would think palliative care comes in and says, you're 88, advanced CHF, we shouldn't be doing this. But that's not the point. The point is that palliative care was able to sit down and really explore for the patient, for Mary and her family, what mattered to them, what the impact of the illness was, and to just make sure that the care they got reflected those goals and values. And it so happened that ended up prolonging life. If life were short because her illness prognosis just happened to be so, it would have at least improved the quality of life of patients. As a palliative care fellow, sometimes I struggle because I came from the internal medicine world of the fixing. And then when I was a palliative care fellow in the winter in Boston, I remember one time thinking, what am I doing here? Everybody's dying, everybody's sad, it's all depressing. What am I doing? And I call this the palliative care fellow existential crisis. And I understood later on, and I'm even more convinced of it now, that what we are doing is we are going in there for a situation that is happening regardless of whether we acknowledge it or not. Regardless of whether they acknowledge it or not, people are dying. People are living with chronic illnesses that are having a significant negative impact on them and their loved ones. And we can go in there and just make it a little less bad, and sometimes a lot less bad. And I think that's worthwhile. So you may not be giving them a new knee, but boy, allowing Mary and her family to be able to spend another holiday together, to be able to be in her apartment and cook because that gives her joy. That's what palliative care does. And I know the healthcare system, and specifically in the US, can sometimes make that look not as glamorous, but that is really the key. It is sort of reconciling medicine with its human side. So it goes back to what that lady told me on that plane. Isn't that just medicine? Well, yes, palliative care is just medicine. And we'll skip this, but the point is the best palliative care is the one that you can provide. I think there's going to be debate for a long time, and hopefully we'll have a little more clarity about when do you integrate specialty palliative care, when do you just strengthen the primary palliative care skills of existing clinicians. I think we can debate that. It's probably very likely that we'll never have enough palliative care specialists to cover all of the needs. So we're going to have to really strengthen primary palliative care, meaning how do we make sure that we strengthen the skills of already practicing clinicians who already do this. And the point is not that doctors or nurses don't talk to their patients. It's that there are ways that we can do it better and do it more in a way that it impacts patients. But that being said, I think whether we do primary or subspecialty palliative care, the point is that if we actually have this palliative care mindset, we're going to lead to a culture change in medicine, which is going to be reconciling medicine back with its primary purpose, which is healing. So we've talked about this. It's all about relieving suffering. It does so with minimal cost. It doesn't have to take place of curative care. It is not just for cancer patients. Even I, the internist, had to remember that. And more research is in the way, and hopefully more research on the island too, because I think the best data is the data that you can kind of collect based on sort of your local realities. And we can all tell you what palliative care can do, but I think don't trust us. The palliative care that is best for you. Again, I'm very repetitive, but I mean it is the palliative care that you can deliver where you are. Thank you very much.
Would everyone like to ask some questions? I mean, there's a lot of data there, fantastic research, you know, really heartens us, I think, here in the Cayman Islands.
Ginny, closer to the mic. No one can hear
Sorry.
you.
It's very encouraging to see the research that you've presented, because we do sometimes struggle with our healthcare providers to realize that palliative care can come a lot earlier, and that early referral is never a mistake. So having data for doctors is really important. They only believe that. And a lot of research is quite difficult in palliative care. So I really thank you very much for presenting that. Any questions, please?
Insurance companies to cover palliative care?
Not necessarily. It depends. So most palliative care, whether if it's provided in an inpatient setting, is going to be covered. The difficulty is because of the different layers of payment in terms of hospice at home palliative care, or if you're at a nursing facility. I won't bore you with the details, but Medicare, for example, will only pay for nursing care if you're at a nursing facility, and not concurrent nursing care plus hospice or palliative care. So you have to choose one or the other. We've come a long way, I think, in terms of just making sure that palliative care in general is covered, but it's when you need it at like a different setting that requires also hospital coverage, that's when it becomes tricky. So there's this donut hole that we have sometimes for patients who need aggressive end of life care and hospice care and have to kind of choose one or the other. So yes, it is difficult, but we've come a long way. We've come a long way.
I'll just add that here in the Cayman Islands, thankfully, because of the generosity of the people in the Cayman Islands, palliative care is free and can be given while you're getting chemotherapy or on dialysis or getting respiratory or any treatment that you want. It doesn't matter because Jasmine services for palliative care are free of charge.
Which is wonderful. That's wonderful. In the US, a hospice organization, for example, gets a carve out. So let's say you get $800 to pay for the patient care for the day. You can choose whatever you do with it. If a patient is getting a treatment or a surgery or a procedure that costs $4,000, you're out of pocket with that. So some of those calculations come into play. And fortunately, some of the larger hospices have enough money that they're able to sort of not worry about those costs. And that's what we call open hospice. So a lot of our heart failure patients, for example, are able to stay home on hospice on ionotropes or have advanced devices, for example, but it is not uniform. So you are very blessed here on the Cayman Island to be able to have it for free. And this is thanks to the wonderful work of the Cayman team. All right. Thank you.
Thanks, Dr. Khan. Yeah, we are actually really incredibly fortunate with the service that we can provide because we are not influenced by insurance companies at all. So we can choose the patients. I mean, obviously we choose appropriate to our service, but we're not limited by insurance considerations. So our next speaker, who we've already met earlier on, is Dr. Natalie Sharp, who's joined us as a palliative care physician from Jamaica. She is a specialist physician in palliative care. She completed undergraduate training in biochemistry at Vassar College in Poughkeepsie, New York. Poughkeepsie, sorry. She returned home to Jamaica in 2006 and attended medical school at the University of the West Indies and went on to do a residency in hematology and medical oncology. During her residency, she developed an interest in palliative care and did a certification course with Harvard Medical School and a clinical stint at the University of Colorado in Denver. One of Dr. Sharp's goals is the integration of quality palliative care into the management of advanced illnesses and providing access throughout all areas of the country. And she is going to talk to us about communication skills and how to handle special situations. Welcome, Dr. Natalie Sharp.
All right, thank you, Ginny, and thank you to everyone who's presented so far. It's been very good. I'm gonna come down here. Yes. Okay, so I like to talk about communication skills because I really believe that the tools work. Anybody who knew me in high school or when I was much younger, they're always surprised when they hear what I do for work because they're like, you never used to talk. You didn't speak when you were younger. And I really didn't. I had a lot of anxiety and I didn't like talking to people, you know, when I was younger. So when I decided to go into palliative care and I realized that, you know, this communication and talking was a big part of it, it was very, very nerve-wracking. But I realized that being a good conversationalist is not quite the same, is not the same as being able to communicate well with patients. And the skills required are not the same. And in palliative care, you learn tools to help you communicate better with patients, and practicing these tools and using these tools are what's going to help you communicate. Oh, let me grab the thing. Okay, so we get a lot of referrals because sometimes doctors just don't know what to say, you know, so it happens a lot. It happens a lot. They want us to have these conversations. But what I want to do is provide you guys with some tools, some of the things that we are taught in order to help you communicate with patients better. So sometimes the common conversations that we have to have are things like establishing goals of care, deciding about treatment options, deciding between, you know, different options that your physician has given you. You know, how are you going to think about it? How are you going to decide? You want to discuss if your disease has progressed, what's happening. You want to discuss, you know, make decisions about imminent death if it's coming, what's going to happen after you pass. You want to discuss complications of your disease or surgery or complications that may happen or may have happened already. And then establishing code status, another conversation that's very important to have. So what is effective communication? And again, it's not just conversation. Communication involves the ability to draw out and identify a patient's concerns, their worries, and their information needs. It involves then tailoring the information appropriately to the identified needs and concerns. And then this enables the patient to be involved in the decision-making process, which is our goal. So good communication is therefore one of the cornerstones of good medicine, and in particular, good palliative care. And it helps to provide information about the disease, and the prognosis helps in making decisions. So without information, patients cannot participate in their own treatment planning, and they cannot give informed consent, they cannot make suitable plans if you don't know the truth about what's going on. So effective communication is the foundation on which rests alleviation of a patient's suffering. Communication is where it all starts. So what are some reasons why we don't get to communicate properly all the time? Sometimes there's not enough time. It's too busy. You have a busy clinic. You have a lot of patients waiting outside. You don't have enough time to, adequately deal with the situation. Sometimes it's uncertainty in prognostication. You're not sure. You're just not sure how long this patient is going to have. You don't know what to tell them. There's a reluctance to discuss a frank prognosis. I know when I first started in internal medicine, and people used to ask me, well, how much time do you have? And in my head, I'd know probably about 6 months. And I'd say, maybe about 6 months. But you never know what's going to happen, right? I would always say it and then I'll take it back, because I just really didn't want to have that discussion. So you have a fear of eliciting strong emotions from your patients. You don't want to cause them distress. Sometimes, you may feel you've done everything you could for this patient and it still didn't work out. You feel like, you failed the patient. Sometimes it's difficult to express empathy. You just don't know how to deal with this person who is having, a response to what you just told them. And then a lot of times as physicians, as medical professionals, we prioritize care of physical needs over care of the patient's emotional needs. And so that's what palliative care wants to do. We want to, bring back in the emotional needs and realize that that's as important as your physical needs. So what happens if we communicate poorly? We end up sometimes with futile life prolonging care, which is in conflict with the patient's values. The patients suffer. They're in distress. Increases psychosocial morbidity for family members if they're unsure of what's happening and they don't understand clearly a plan. And then it results in underutilization of hospice and palliative care services, because if you haven't discussed it with your patient, you are unable to make a proper plan. For healthcare professionals, it provides moral distress. You know what's happening, you just don't know how to tell your patient what's happening. That can cause emotional burnout. You're stressed out because you have all these things to deal with. And then also it can increase economic costs for your healthcare system, your hospital, or whatever your service you're providing. So when we talk about communication, before we even start about talking, we have to talk about listening, because good communication starts with listening. And listening and attending are the most important aspects of being a healthcare professional. Everyone needs to be listened to. And if we can listen to someone, we can really help them. Listening, as Dr. Basti mentioned before, it's a process of hearing the other person. This involves not only what they say, but also a whole range of other aspects. Listening is not the same thing as just waiting to speak. What we want to do is listen and attend. Attending is an act of truly focusing on the other person. It involves consciously making ourselves aware of what a person is saying and of what they're trying to communicate to us. It's concerned with our attention. So I'm going to go through just 3 basic techniques that we're taught when we're learning palliative care. I think these techniques can be useful in many situations. And I think, if we practice them, we can all find a way to use them in our work. So the first one is spikes, which is, a framework for having a serious conversation with a patient. Then ask, tell, ask is one that's recommended for when you're trying to break bad news. And then nurse is another one that's used when you're responding to strong emotions. So with these communication tools, they require practice. Practice, practice, practice. Like I used to have a little card that I would look at before I went into the room, and I would say, okay, first S, then P, then, I had to remember it. And after a while, it becomes routine, but you do have to practice these things. You want to pause, take a breath, run through the technique in your head before starting. Do not skip a section. These are actually very purpose-built techniques. Each thing follows another. And so, don't rush through it. Don't skip over any parts of it. And just remember, you will never have the right words 100% of the time, okay? Sometimes you may, say the wrong thing, just take a pause, step back and reframe and restart. So spikes stands for setting, perception, invitation, knowledge, empathy, and then summary and strategy. So setting, you want to think about where you're having the conversation. Be as private as possible, a room with a door that can close where you're not likely to be interrupted. Preparation, you want to be prepared when you're going in. Review the patient's charts, review their most recent blood work, their most recent scans, whatever you have to discuss with the patient, be prepared. And also be prepared with whatever tool it is you're going to use. You want to involve anybody who's important to the process, the relatives, the significant others, anybody else on your medical team, anybody who you think really should be there in this discussion. You want to turn your phone off. I prefer not on vibrate, I prefer it just off because it's very disconcerting when you've just given somebody bad news and then ring, 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 the phone acts and you have to stop. So yeah, phone off. You want to consider how you've set up your room or your office, right? Are you behind the desk? Are you beside or directly across from the patient? I prefer to have everybody sitting in a circle. I usually seat myself beside the patient or beside the main family member as appropriate because I like to hold hands. I'm a hugger. I like to be beside the patient. You want to have everybody sitting down. So, ahead of time, try to make sure you have enough chairs for all the people who are going to be present. It's a little disconcerting when somebody is hovering, and everybody else sitting down. And then you want to introduce everybody in the room. Make sure everybody knows who everybody else is. All the relatives, how they're related, everybody on your team that's present, just make sure everybody knows each other. And also, one of the things I like to think about on the introduction is if you are in a situation where a patient is not part of the discussion. For example, somebody who is very advanced and you're having the discussion with the family members about making a decision. I like to think about introducing yourself to the patient. So I know about your dad's medical illness, but tell me more about him before he became sick. Tell me more about him, about who he was as a person. What kind of work did he do? What kind of father was he? So those are the things you kind of want to know about a patient at that point in time. So P is for perspective and perception. This is the time where you're trying to find out what they know about the illness and what's going on. So tell me how you ended up here. How much do you know about what's going on with your mom? What has Dr. Smith told you so far about your disease? How do you think this illness is going to affect you? So what you're trying to do is draw out information from them about what they know already. The I is invitation. What you're trying to do here is you want to determine how much the patient and family know about the illness. No, sorry. Invitation means you want to, you're asking permission to let them know about what's happening. So would you like me to tell you what's going on? Would you like me to break down what this report really means? We have these test results back. Can we talk about them? Would you like to know what to expect going forward? So you're not just going to blurt out the information. You're going to introduce it and you're going to ask them if it's okay to give this information. Then knowledge. This is the point now where you deliver the information. How do you do that? Don't use euphemisms. Just, tell them exactly what is going on. They want to know exactly what's going on. All right? Don't be excessively blunt, however. Give the information in small chunks. So don't ramble on about everything that you've discovered since the last visit. Just break it down piece by piece and give them a chance to respond or digest the information after each piece of information. Allow room for them to ask questions. And then you want to check in to see if they're processing the information the way you're delivering it. And then you want to repeat any important points if needed. Another part about knowledge is you might want to give a heads up if the information is bad. A way you can do this is, this is more serious than we originally thought, or this is not what we wanted to hear. This is not what we were hoping for. Then the E is empathy and emotion. You want to acknowledge emotions in the room and respond in an appropriate manner. How do you feel about what I just told you? I wish the news were better. What worries you most about this? What you're trying to do now is, gauge how what you've told them has check frequently that you guys are all on the same page. Just so we're okay, we have a plan. And then you want to make sure that everybody knows what they're supposed to do when they're leaving this meeting, okay? You as a physician, the relatives, the patient, everybody knows what their next steps are. The next one is ask, tell, ask, which is commonly recommended if you're breaking bad news to a patient. And of course, spikes still, applies because you always want to think about setting, etc. And then you get into ask, tell, ask. So breaking bad news is often not just one conversation, but it can be a series of conversations over time. The details of the approach will vary, but always use the ask, tell, ask protocol. You can use it with family members or you can use it with the patient. What ask, tell, ask is a back and forth cycle between the patient and the health professional. It addresses 4 things: the patient's perspective, the information that needs to be delivered, the response to the patient's emotions, and then the recommendations that you're going to make at the end. So ask. The first ask, the goal is to build the patient's trust. How are you doing compared to a year ago? I would like to respect your wishes for the future. Is it okay to talk about what you would want? You want to determine the patient's goals for treatment. What is most important to you while you're receiving treatment? What things are you hoping for? So really you're trying to just, set a scene, figure out what they're thinking. Then now we tell, right? You're going to explain the overall condition, including the most serious problems. You want to discuss any likely future complications. And then you want to, if you can, bring in discussion about informed decision-making, such as DNR or CPR. Then after you've given this information, stop talking. Just stop talking. You're going to sit in silence for a little while, right? And you're allowing the patient to digest the information that you just told them. So like when we're practicing these tools, we also practice sitting in silence. So what they used to tell me is that, you deliver the information to a patient and you just stop. And then when you're starting to feel uncomfortable, you think the silence is going on too long, then count to 20, because it's usually shorter than you've thought, right? And ideally, you want the patient to respond first. After you've broken the bad news, ideally, you want them to say something first, all right? You're allowing them to process, you're allowing them to ask for more information, and you're allowing them to express their emotion. Do not rush to the next step. Take your time. And then we get to the last ask, which is, you find out what else they have going on. So what questions do you have? Or in your own words, please tell me what you understand from our conversation. Or what will you tell your family about what we discussed? So what you're doing is trying to see how they received everything and what they're planning to do going forward. So the third technique that I want to bring up is nurse. So nurse is particularly helpful when you're responding to big emotions. And it's something that's advocated for use with both patients and with colleagues as well too, right? So yes, useful to respond to big emotions. It helps to keep the lines of communication open and it reduces tension. It gives you a way to respond empathetically and be fully present in a conversation. And it can help build your relationship with your patients and with your other team members to improve the quality of care. So when do I use nurse? There are verbal cues, yelling. I mean, clearly somebody's yelling, it's a big emotion. But if you're getting just short, curt responses, if they, just don't want to talk to you, or if you're hearing tremors in the voice. So those are some things that will tell you that, this patient is not dealing well or not coping with what you're saying. Then there are the nonverbal cues. Their arms are crossed, their brow is furrowed, they're not looking at you. Their jaw is clenched, hanging their head and crying, of course. These are things that will, signify big emotions. So nurse is naming, understanding, respecting, supporting, and exploring. You're going to name what the person is feeling, right? Many people in this situation would feel scared. Yes, seeing so many doctors can feel overwhelming. It can be really frustrating when someone doesn't communicate well, or I'm wondering if you're feeling nervous. So all of those sentences, you've named the emotion that the person is feeling. I try to stay away from the word angry because anger is kind of a much bigger emotion that's a lot harder to deal with. So I tend to try using words like frustrated instead of anger. But what you're trying to do is validate how the person feels before jumping to a solution. Next is understanding. What you're trying to do is take steps to better understand their point of view and try to get them to share more. So, this conversation really helped me to understand what you're thinking. I can see this is important to you, or tell me more about what's happened. You're trying to align yourself with the person and let them know that you're on their side. Remember, what we're trying to do is de-escalate a situation here. Respecting. You're going to show respect by helping them see what is going well. Highlight the things that they're doing in this stressful situation. If it's a colleague, I can really see how dedicated you are to your patient, or you're such a caring daughter, or I really admire your love for your family. You're going to redirect feelings to something more positive and show respect for the things that they value. Then you're supporting. Now you're going to reassure the person that you and the others are working with them. It's not enough to say, I support you. You need to be more specific about it. So I will do my best to make sure you have what you need to do your job properly, or our team is committed to helping you in any way we can, or we will work through this together. The support is important. And then E is exploring. You're going to explore the next steps and clarify any remaining questions you may have about their feelings. So tell me more about what you mean when you say you don't want to give up, or help me understand what you need or what I can do to help you do your job well, or tell me what good communication between us would look like for you, right? So you're trying to figure out how we're going to solve the situation. So nurse can help de-escalate situations. It appropriately recognizes particular concerns, you're listening with intent, and you're responding empathetically. So I've given 3 basic tools. It's important to, as I said, you keep them with you, you think about them before you go into any conversation, you think about which one is good that you're going to use, and eventually it becomes automatic, Practice, practice, practice. As I said, have them written down and take a quick look before each conversation. Practice with your colleagues. It may feel weird, but it does help to practice. Take a pause before you start the conversation. Go through each step in your head as you talk. And then one thing that's important, if you're having a conversation with family, with a patient, and you are talking more than them, you're doing something wrong, right? They should be talking more than you are. So if you are doing all the talking, pause, reframe the conversation, and go at it from another angle. So I'm just going to talk about some special situations in which we can, use these tools and take them, or give you some responses that you can, kind of tailor for your own use and for yourselves. So how to have a goals of care conversation and introduce palliative care to your patients. So you need to first identify what their expectations are. You want to give the family time to voice their values and their priorities. You want focus that the focus is on the patient's wishes and not the family's particularly. So helpful questions. What would your dad want to be the focus of his care with the knowledge that he's dying? Or what are you hoping for from mom? What things are you afraid of? What is necessary to make life meaningful for your wife? What do you expect in the future going forward? What are you hoping for in the time you have? And what would you want your life to be like if you were to become much sicker and less independent in self-care? So these are some kind of questions, depending on the type of conversation that you're focusing on, to kind of help you figure out what the patient's wants are and what their values are. You're going to give a big picture of the medical condition. You do it in layman's terms, because what happens is often the patients and family may have unrealistic goals of care, and your job is to kind of redirect them to something that's more attainable. For example, somebody with, stage 4 cancer with liver failure, they're not going to make it to see their granddaughter's graduation, who's now 2 years old, right? So things like that, you kind of have to reframe on what things are realistic and they can expect. You want to then take time to clarify and stress the big picture in relation to the disease and their goals and wishes. So you're kind of tying all the information you've gotten and putting it together. What if there's a non-consensus? It happens. I remember a particular situation I had where I had a patient, the mom was 92, she had advanced colon cancer. She'd been through multiple different treatments. She was now, non-communicative, non-responsive. She had 9 children, right? So some of them wanted to do everything they could, try another treatment. Some of them wanted to just, give support, provide palliative care. And then there were a few that were flip-flopping back and forth, and we had many, many meetings, but it was very difficult for them to reach a consensus. And it happens sometimes. And what you have to do sometimes is, again, to bring it back to the patient. What would your father say? What would mom say if she could speak? You want to give this time for the family to discuss and reconvene later. Multiple meetings may be necessary. You want to utilize resources that may be helpful. They may have a minister or, a chaplain that they're close to. A social worker could be helpful. Their primary care physician may know a lot more about them and their family than you do. A nurse who's been particularly close to them, their home care team. We have patients at Jasmine who sometimes are admitted to hospital. We've been seeing them at home for, a long time, then they're admitted to hospital. It would be a good time, we can be involved in their care while they're in hospital because we've known them. We know what's important to them. We know what their home life is like. So really it's important to utilize resources to make these decisions, and time and trust are key. So it's better to do these things earlier. Then you want to establish your plan. You're going to give medical recommendations based on the goals of care. So based on the things that you discussed, that's what your recommendations are. You want to focus on what you can do to keep the patient's quality of life good for the remainder of their life. And you want to establish treatments that are not in line with goals of care. For example, so you're saying that you want to stay home and you want to be at home for the rest of you don't want to go back to hospital. So if something happens in the middle of the night, you don't want us to call an ambulance to take you back to hospital. So you want to think about things that are not in line with what they've told you. So you're establishing a plan now. So for example, so I gather from our discussion that it's very important for your dad to be near family and be pain-free. I also hear that it's important for him to return home with his family caring for him. Am I right? Is that what I'm hearing? You reassess the family's agreement. And then you could say, well, one way we could assure these goals is to arrange a support team in the home that could manage his pain, other symptoms, and support your family with his care, such as Jasmine, right? But that's one way you can introduce it. You can provide it as support for the family at home. So sometimes we get, in these conversations, we get some very specific questions that are often very difficult to answer. So something like, how much time do we have? Can reframe it like, well, I can't predict a date, but given the course of most patients with your disease, we're probably looking at days to weeks, weeks to month, whatever you think is appropriate, but don't take it back like I used to, okay? Another question is, what if God intends a miracle? We get that a lot, right? What you want to do is validate the family's beliefs. You do not want to impose your own, whatever your own beliefs and judgments are on the family. An appropriate answer could be, if a miracle is what you believe and what God intends, it will happen no matter what. So I can only recommend care for what is happening now here in front of me. Should we go to cancer treatment center of X, Y, and Z? Is another question that we can hear sometimes. You can let them know that, we are not holding back any care that will help or reverse this process here. If I had any other treatments, I would not hesitate to give it to you, but unfortunately, there's nothing else available for you now. So the last thing I want to bring up is discussing DNR orders, because that's always very difficult and it's hard to do. The same principles apply. Spikes, ask, tell, ask, determining goals of care, because you're not having a DNR conversation. A DNR conversation is really a goals of care conversation. It's just another type of goals of care. So how to start. You can say, I'd like to talk to you about some decisions to be made so that I can respect your wishes going forward. Ask the patient to consider the future. What do they expect? What do you expect in the future? How do you see things going forward? What goals do you have for the time that you have left? And I like that last one because you are subtly saying that, there is a finite amount of time left, and getting them to think about that. And then when you're talking to them, you clarify what they finally told you. So what you're saying is you want to be as comfortable as possible when the time comes. I actually would like Dr. Rosenberg's picture that he gave in the beginning about the patient talking about what comfortable looked like to him. Or you could say, what you're saying is you want us to do everything we can to fight, but when the time comes, you want to die peacefully. And then you always want to ask, can you tell me why you feel this way? You don't just want them you don't just want to stop at this particular decision. You want to understand why they made this decision. Sometimes it's not that easy. Sometimes, they don't just, say, okay, yes, I want to die peacefully. Sometimes they just want to have the CPR discussion. And you have to figure out why they want CPR, right? So why do some people with advanced illnesses still opt for CPR? Again, can you tell me why you feel this way is an important question. One reason people opt for CPR is because they have inaccurate information about it. If we were to believe TV shows, and all that kind of thing, CPR works 60 to 85% of the time. Studies have been done that show that that's what people believe, right? But the actual survival after CPR to hospital discharge is about 10 to 15% for all patients. If you're thinking about patients with serious illnesses and people who are elderly, it's less than 2%. And then in that less than 2%, actually most of them end up on life support if CPR is successful. A lot of people in the general population do not have an awareness of these facts. They think it's going to restart your heart. And I think, so one of the things to start with is, what do you know about CPR? And then you want to clarify what CPR can achieve and what it cannot achieve. Another reason people will say they want to do CPR is strong emotions, hope, fear, guilt, things like, I haven't been here for my mother all these years and now she's dying. And it's, you know, it's hard for you to then make the decision, or I'm afraid to make a decision that could end my wife's life. Or I feel like I'm giving up and choosing to die if I sign that. So you have to, so that's why it's important for you to ask why they're making the decision that they're making, because now you know that these are the concerns that this particular patient has. So you can then follow up a conversation. This decision seems hard for you. I want to give you the best medical care possible. I know you still want CPR, but can you tell me more about your decision? You want to probe with open-ended questions. What do you expect to happen? Is there something you think could be done differently after the resuscitation that wasn't being done before? You know, so things like that, just kind of get probing. You want to reassure them. You want to clarify that the orders and plans that will accomplish the overall goals you have You want to clarify orders and plans that will accomplish the overall goals you have discussed, not just a DNR order. Remember, it's not just a DNR conversation. And you want to let them know that a DNR order does not address any other aspect of care other than CPR and resuscitation, right? So you're something like, we will continue maximal medical therapy to meet your goals. However, if you die, I'm not recommending CPR to bring you back. Or it sounds like we should move to a plan that maximizes your comfort. Therefore, in addition to a DNR, I'd like to talk to you further about other things we can do to maximize your comfort. So, and then what? I mean, it may not always wrap up nice and neatly. It may need to be a series of conversations. The families, the patient may need time to think and process. That's why it's beneficial to have the conversation earlier rather than at times of crisis. And then you make a plan to revisit the conversation. Okay, take some time to think about it and we can talk about it another time. But again, using the techniques that I described before, spikes, ask, tell, ask, does give you a better chance of having a successful conversation, I promise. So in summary, effective communication is a key component of palliative care and should be an essential part of understanding your patient and their families. Communication is a skill like any other, just like you practice your respiratory exam, your cardiovascular exam, communication should be practiced in the same way. The recommended technique should always be followed in the recommended sequential order. And I mean, I like this quote, communication is something, if we do it badly, they may never forgive us. If we do it well, they will never forget us. Thank you very much.
We are running a little bit late, so if there's any burning questions, can we have them? Otherwise, perhaps you could speak to Dr. Are you here tomorrow? Yes. Yes, Dr. Shop is here tomorrow, or you can meet her afterwards. But any particular immediate questions?
You can always catch me outside.
Well, thanks, Dr. Sharp. That was really amazing. I mean, I think those are really practical suggestions and tools. Sometimes people do these things, they don't really know what they're doing, but we have to be conscious of it. I think we do a much better job. And some people are better communicators, other people come naturally to it, other people don't, but everybody can learn these tools. And really the last quote just says it all, doesn't it? So I'm going to ask Felicia to come and give vote of thanks. And thank you very much, Dr. Sharp. Thank you.
I'll just leave it on. So just a little bit of housekeeping rules. You guys have been absolutely amazing, despite the fact that we've gone behind time. I'm pleasantly happy with how many people have stayed to hear all the amazing speakers tonight. Tomorrow, we will have another great lineup of speakers. We'll hear from Dr. Shiv here again with dementia, and Dr. Donna Thompson. Where do we go from here? But on top of that, we're going to have our holistic panel discussion with a respiratory therapist, acupuncturist, grief, just kind of looking at all the supportive services that go along with palliative care. And then also we'll have our doctors on the hot seats, as well, that you can ask them questions. Just flips beside me. I just want to quickly say a huge